I spun my chair around. We made the floor our river with one easy sound. Friends at the table, passing fruit in lines. Everybody grinning like we hit the right time. No need to plan, no need to chase. Let the whole house shine at a slower pace. We got light on the wall, and the simple little moments feel like it's all. Today is enough. Today is enough. We can lean back, laugh loud, and let the good stuff. Today.
Many people come over and over, like it's never stop, even increasing. To help patients from around the world. We design to maximize your experience. Welcoming environment to combat patient anxiety and stress. Focuses on delivering a comprehensive treatment. Caring attitudes toward patient to help facilitate your needs and to realize patient satisfaction. This is not a job. This is a machine to fulfill their needs, their requirements. The comprehensive scope of clinical and health with our integrated system. The latest equipment is utilized throughout the hospital. Technology is critical to delivering our high standards of health. Patient care services are coordinated across the various functions, activities, and operating units of a system. Research and innovation leading the future of heart medicines. Serve with kindness. Wherever you are, wherever you need, we here for you. Rumah Sakit Jantung Jakarta, a place where your heart feels safe.
Marilah kita menjadi manusia yang bermanfaat bagi orang lain dan juga orang tua kita dan negara kita.
Saya Dr. Fatima Jan Rahmat, Presiden Komisaris Dikardia Indonesia. Selama lebih dari 30 tahun saya telah berada di industri kesehatan dan menyaksikan bagaimana cara kita melayani pasien terus berubah. Di dunia kesehatan yang terus berubah, di mana teknologi yang bergerak sangat cepat, tekanan regulasi yang semakin berkembang, dan ekspektasi pasien yang semakin tinggi. Kepemimpinan hari ini tidak lagi hanya soal mengelola organisasi. Kepemimpinan adalah tentang bagaimana kita berpikir lebih jauh, melihat sistem secara utuh, dan memastikan setiap keputusan berdampak langsung pada kualitas perawatan pasien. Melalui apa yang kami sebut sebagai New Mind of Future Precision Medicine, provides early diagnosis for accurate treatment to improve patient outcome. Kami memandang layanan kesehatan, khususnya jantung dan kanker, bukan lagi sekedar rangkaian tindakan medis, Bagi kami, layanan kesehatan adalah ketepatan diagnosis, kecepatan pengambilan keputusan klinis, dan kesinambungan perawatan pasien dari awal hingga akhir. Sebagai pemimpin, saya belajar bahwa kita tidak boleh hanya berpikir tentang layanan yang terlihat di depan pasien, tetapi juga tentang sistem yang berada di belakangnya, proses yang terjadi, collecting data, integrasi data, interoperabilitas data, penggunaan teknologi yang terkini, dan AI, serta kolaborasi dan ketepatan informasi menjadi sangat penting. Inilah makna Think Beyond Services. Membangun fondasi operasional yang memungkinkan dokter dan tenaga kesehatan mengambil keputusan terbaiknya pada waktu yang tepat. Karena itu, kepemimpinan hari ini harus mulai melihat peran precision medicine, predictive medicine, dan diagnostik klinik serta laboratorium klinik lainnya seperti genomik bukan sekedar unit pendukung, tetapi sebagai fondasi operasional dalam pelayanan rumah sakit sekarang ini. Laboratorium klinik dan diagnostik klinik serta imaging yang akurat, cepat, dan terintegrasi bukan hanya meningkatkan kualitas diagnosis, tetapi juga mendorong operasional lebih baik, mendorong operasional excellence, efisiensi, dan keselamatan pasien. Inilah peran kepemimpinan, memastikan setiap elemen sistem, termasuk laboratorium klinik dan penunjang medis lainnya, berkontribusi nyata pada kualitas layanan kesehatan yang lebih baik dan berkelanjutan. Salam sehat dan salam kesehatan Indonesia.
Interventional specialists begin each day knowing one thing: every decision matters. Their choices shape outcomes for the patient, for families, and teams working in perfect coordination. Confidence is something they train for, strengthened through years of learning and preparation, ready when the moment allows no hesitation. At Terumo Interventional Systems, we exist for those moments by supporting focus in critical situations and mastery across a lifetime of practice. Our learning strengthens understanding. Our solutions are intuitive and dependable, engineered for consistency and reliability. Because when every decision matters, there can be no compromise. Terumo Interventional Systems. When every decision matters.
Dengan dibukanya Poliklinik Eksekutif Gria Kardia, kami harap dapat meningkatkan mutu pelayanan dan kenyamanan pasien loyal Rumah Sakit Jantung Jakarta. Di Indonesia, Rumah Sakit Jantung Jakarta hadir sebagai pusat layanan jantung berteknologi tinggi bagi pasien anak hingga dewasa dengan standar pelayanan yang komprehensif dan terintegrasi. Layanan kami didukung fasilitas penunjang diagnostik yang lengkap, mulai dari EKG, ekokardiografi, Holter, treadmill test, MSCT, hingga MRI. Penanganan pasien jantung diperkuat oleh tim medis berpengalaman yang terdiri dari profesor, subspesialis, spesialis jantung dan pembuluh darah baik dewasa maupun anak, serta tim bedah jantung yang berkompeten. Kami menyediakan layanan unggulan meliputi rotablator, aterektomi, IFUS, dan OCT, serta penanganan aritmia dengan teknologi PFA dan pemasangan pacemaker. Kami juga menghadirkan tindakan bedah jantung, mulai dari minimally invasive cardiac surgery hingga prosedur kompleks seperti bental prosedur. Kami juga menangani katerisasi dan bedah jantung anak mulai dari ASD, VSD, TOF, dan atrial switch operation. Dengan teknologi, keahlian, dan kepedulian, kami siap melayani Anda untuk jantung yang lebih sehat. Halo, saya Diva, Virtual Assistant AI buatan Rumah Sakit Jantung Jakarta. Dan inilah JHC Hospital Mobile. Di era digital, pelayanan kesehatan harus bergerak lebih cepat, lebih mudah, dan lebih dekat dengan pasien. Mengatur dan memperbarui data diri dengan mudah. Hanya dengan scan KTP, data kalian akan terisi dengan cepat. Dan ini saya, Diva. Saya hadir untuk membantu Anda mengakses riwayat medis Anda secara lengkap dan terintegrasi. Semua tersimpan dengan aman untuk mendukung pelayanan medis yang lebih tepat dan berkesinambungan. Anda dapat menemukan layanan kesehatan terbaik dengan harga yang menarik. Memilih paket pemeriksaan sesuai kebutuhan Anda, membantu Anda merencanakan evaluasi kesehatan jantung dengan lebih mudah dan nyaman. Melihat dan mengelola informasi mulai dari pendaftaran layanan hingga informasi pelayanan medis. Anda dapat memantau jadwal kunjungan Anda secara mudah dan teratur, hingga melihat antrian layanan yang berjalan secara langsung. JHC Hospital Mobile memberikan pelayanan kesehatan jantung yang semakin mudah dan terpercaya.
Lithotripsy is a medical procedure to treat hard calcifications such as kidney stones or calcium in coronary arteries by breaking and fracturing the hard deposits. The Lithics HC IVL catheter is the first IVL technology to safely and effectively treat calcified lesions without the need for an external energy source. The Lithics catheter uses unique metallic hemispheres to exert Hertz contact stress energy to safely fragment calcium in moderate to severely calcified lesions. Lithics is flexible and can easily navigate tortuous anatomy. The lithotripsy mechanism of action is activated by simply inflating the Lithics catheter using a standard indeflator device. At low nominal pressure, the Hertz contact stress initiates calcium fragmentation. Lithics is designed to fragment calcium while maintaining safety and avoiding dissections and perforations. Lithics is atraumatic to soft tissue due to the large contact area and energy absorption. Deep and wide cracks can be seen in eccentric and concentric calcium, enabling optimal lesion treatment. In a clinical study, multiple cracks were observed in over 75% of calcified lesions. Following IVL, optimal device expansion and lumen gain is achieved. In the Pinnacle 1 study, residual stenosis was less than 30% after stenting in 100% of lesions. Stent expansion at minimum stent area was 96.7%. Stent expansion at maximum calcium site was 103.4%. Visit elixirmedical.com for more information.
Many people come over and over, like it's never stopped, even increasing, to help patients from around the world. We design to maximize your experience. Welcoming environment to combat patient anxiety and stress. Focuses on delivering a comprehensive treatment. Caring attitudes toward patient to help facilitate your needs and to realize patient satisfaction. This is not a job. This is a machine to fulfill their needs, their requirements. The comprehensive scope of clinical and health with our integrated system. The latest equipment is utilized throughout the hospital. Technology is critical to delivering our high standards of health. Patient care services are coordinated across the various functions, activities, and operating units of a system. Research and innovation leading the future of heart medicines. Serve with kindness. Wherever you are, wherever you need, we here for you. Rumah Sakit Jantung Jakarta, a place where your heart feels safe.
Marilah kita menjadi manusia yang bermanfaat bagi orang lain dan juga orang tua kita dan negara kita.
Saya Dr. Fatima Jan Rahmat, Presiden Komisaris di Kardia Indonesia. Selama lebih dari 30 tahun saya telah berada di industri kesehatan dan menyaksikan bagaimana cara kita melayani pasien terus berubah. Di dunia kesehatan yang terus berubah, di mana teknologi yang bergerak sangat cepat, tekanan regulasi yang semakin berkembang, dan ekspektasi pasien yang semakin tinggi. Kepemimpinan hari ini tidak lagi hanya soal mengelola organisasi. Kepemimpinan adalah tentang bagaimana kita berpikir lebih jauh, melihat sistem secara utuh, dan memastikan setiap keputusan berdampak langsung pada kualitas perawatan pasien. Melalui apa yang kami sebut sebagai New Mind of Future Precision Medicine, provides early diagnosis for accurate treatment to improve patient outcome. Kami memandang layanan kesehatan, khususnya jantung dan kanker, bukan lagi sekedar rangkaian tindakan medis. Bagi kami, layanan kesehatan adalah ketepatan diagnosis, kecepatan pengambilan keputusan klinis, dan kesinambungan perawatan pasien dari awal hingga akhir. Sebagai pemimpin, saya belajar bahwa kita tidak boleh hanya berpikir tentang layanan yang terlihat di depan pasien, tetapi juga tentang sistem yang berada di belakangnya, proses yang terjadi, collecting data, integrasi data, interoperabilitas data, penggunaan teknologi yang terkini, dan AI, serta kolaborasi dan ketepatan informasi menjadi sangat penting. Inilah makna Think Beyond Services. Membangun fondasi operasional yang memungkinkan dokter dan tenaga kesehatan mengambil keputusan terbaiknya pada waktu yang tepat. Karena itu, kepemimpinan hari ini harus mulai melihat peran precision medicine, predictive medicine, dan diagnostik klinik serta laboratorium klinik lainnya seperti genomik, bukan sekedar unit pendukung, tetapi sebagai fondasi operasional dalam pelayanan rumah sakit sekarang ini. Laboratorium klinik dan diagnostik klinik serta imaging yang akurat cepat, dan terintegrasi bukan hanya meningkatkan kualitas diagnosis, tetapi juga mendorong operasional lebih baik, mendorong operasional excellence, efisiensi, dan keselamatan pasien. Inilah peran kepemimpinan memastikan setiap elemen sistem, termasuk laboratorium klinik dan penunjang medis lainnya, berkontribusi nyata pada kualitas layanan kesehatan yang lebih baik dan berkelanjutan. Salam sehat dan salam kesehatan Indonesia.
Who support us preparing all this event along the way. So again, thank you, and hopefully this is not the first and the last, but this is the beginning of our partnership for upcoming program. Thank you.
Thank you. So we will move from reviewing the cases to understanding the strategy. To start today's program, we will first look back at what happened yesterday. We had 4 live cases with different clinical and anatomical challenges. What did we learn? What worked? What could have been done differently? So to take us through the highlights of yesterday's 4 live cases and the final result, we are pleased to invite Dr. Johannes Edwin Budiman to actually present the case review and summary.
Thank you, Dr. Andini. Good morning, everyone, to Professor Lee. Good morning, and to our consultants, in-house consultants, Dr. Wisnu, Dr. Andi, Dr. Rizky, Dr. Mardo, Dr. Marulam, and also Dr. Hengki, as well as all the vendors and all the participants who have been joining us online. Welcome to the second and final day of our live cases today. My name is Edwin from Jakarta Center, and I will be reviewing and maybe provide a brief summary of yesterday cases that we have been done incredible job by Professor Lee as our special guest, and also by our proud in-house operators and co-operators. Before we begin, we would like to thank Terumo for mainly sponsoring this event, and also big thanks to Elixir as the supporting sponsor. At the end of this case review, there will be guest lectures by our special guest, Professor Jo Myung Lee from Samsung Medical Center, South Korea. Next slide, please. To summarize, there were a total of 4 cases yesterday with its own uniqueness from each cases, and have been done incredibly well by our special guest, Professor Lee, and also from both operators and all co-operators. Before we continue. Yes, please, Dr. Wisnu.
So I will be moderating this session, and this should be a very relaxed session. So we don't have any strict timeline. So I think we should just discussing the case about what was the strategy, what was the thinking of the operator's mind, and what was discussed. And probably if someone would have done it differently, just please state your mind. It's really okay. Nobody's judging anyone. Thanks. Okay, Dr. Aiden, please.
Okay, thank you, Dr. Wisnu. So as Dr. Wisnu said, this is an interactive case discussion. Please enjoy. If you have all of the on-site and online attendees have any questions, please free to ask questions or comments or queries. So this is the first case that we did yesterday. There's a 70-year-old male with the typical angina, has no previous cardiovascular intervention, and also have echo show a good LVF in 72% with no valvular dysfunction. So this is the angiography from a lady. Dr. Vishnu, if you have any comments, the floor is yours.
It looks a bit simple, to be honest. So it's a simple bifurcation lesion, but at the first I was not really noticing the lesion in the proximal part because it was overlapped. So, but I first demonstrated nicely that we did have a significant proximal lesion. What was your first thinking when you saw this angio, Dr. Lee?
Yeah, actually the mic is not working. Yes, this is very good educational case. When I first saw this case, actually the taking good diagnostic angiogram is the beginning of the procedure. But as you can see in here, in left panel, the AP cranial view, there were much overlaps among the circumflex, obtuse marginal, LAD, and diagonals. So we cannot accurately assess the distribution of coronary arteriosclerosis. And right panel, RAO cranial view, also it is very difficult to see the extent of the region. So in this case, we should look more closely the caudal view, RAO caudal or AP caudal view, and basically review the coronary angiogram is the beginning of the procedure. So we took that oh, okay, yeah. So actually, everybody can know this medial LAD bifurcation lesion. However, the key is that this proximal angulated lesion cannot see very clearly on this screen. So we should check the RAO caudal or AP caudal view. So, and those caudal view also was not so clear. So that's why we decided to use IVUS as a pre-interventional evaluation. And it turns out to be, those proximal related lesions were calcified plaque. They were calcified plaque around here and also significant stenosis. That means we need long stem. So that was my first impression.
Probably anyone else want to note anything from this angio? Okay, we can just move on, Dr. Edwin. Okay, so this was the IFOS finding, running from the mid LAD after the lesion. This whole part is a bit small. This part is probably 3-0. You already seen some significant fibrous plaque. And that's probably the part that we should discuss, because I think the arc of the classification is quite significant, more than 270. What do you think?
Yes, actually it was not clear on the baseline angiogram. However, IVUS showed the medial-related lesion just above the diagonal branch. There were concentric calcification, and the length was around 3 to 4 millimeters. So that means the calcification may be the problem for the good stent expansion. So, however, we should remember that IVUS or OCT cannot tell you the hardness of the calcification. It can show you the calcium arc and length. However, the hardness of calcification, it cannot be told by intravascular imaging. So in that case, we should see the balloon response. So like cine angiogram or stent boost image, after inflate the balloon, you should check those stent boost or cine image to check whether the target lesion were fully dilated or not. So if that initial balloon response is not so good, in this kind of lesion, the concentric calcification and more than 3 millimeter in length, then we need advanced lesion preparation. And another issue in this case is a very tortuous middle to distal LAD segment with the severe myocardial breaching. So in such a case, it is not easy to select distal stent landing zone because myocardial breach always accompanied with slight negative remodeling. So over-dilatation of that segment can result in coronary perforation. So selecting appropriate stent size is very important. So based on those regions, I think IVUS was essential for this case. Right here.
Yeah. Just play it, please. Please, yes. Just play the IVUS. Yeah, just, it's okay. Just move to the middle part. Okay.
Yeah, this one was the initial pullback imaging, and you can see this deep myocardial breach and negative remodeling.
Yes.
If you land the stent at that segment, it can result in the perforation.
Yes. So yesterday, you only using semi-compliant balloon. So I would have chose at least an NC or a scoring balloon, or even cutting in this situation.
Yes, that's a good option. But the reason that I choose semi-compliant balloon was because the medial LAD myocardial breaching and negative remodeling segment. Based on the IVUS, the appropriate stent size is around 3/0 millimeter. However, 3/0 NC balloon might be too big for the negative remodeled medial LAD segment. So, and in coronary angiogram, it was not easy to select the accurate balloon target segment. So if that NC balloon will go slightly down and we do the 12 atmosphere, it can result in the severe complication or severe dissection at the mediality segment. So that's the reason that I choose the semi-compliant 2.5 millimeter balloon and see the balloon response. And then the initial result was excellent. So we could proceed stenting.
Okay, probably we can continue. Oh yeah, Dr.
Thank you, Prof. Lee, for your interesting insight about the using of semi-compliance balloon to, it means like you need to palpate the lesion using the compliance balloon to know the manner of the vessel after ballooning with the semi-compliance balloon. And my question is, after preparation using the 2.5, I mean, the balloon you mean to palpate the lesion, to know whether it is a hard one or not. I just wonder when you want to use like stent or DCB, I thought that we need to prepare with a proper 1-to-1 size balloon before inserting the stent or the DCB. What do you think about it? Did you check with IVUS first before putting the stent, or you have certain parameter to make sure that, okay, it's okay, you can stent? I just want to make, what is your tips for that? Thank you.
Yes, that's a very good question. And before implantation of the stent, the essential is a full expansion of the target region. As in this case, after the 2.5 millimeter semi-compliant balloon up to 12 atmosphere, actually resulted in very nice region expansion. So in the case, we can proceed with the stenting. However, if the semi-compliant balloon was not fully expanded at the calcified region segment, then we can use 3O 1-to-1 size NC balloon to further dilate the region. And for the DCB, as you told me, the 1-to-1 size region preparation is a key determinant for the successful DCB angioplasty. However, there are some things that you should consider, like side branch ostium, like this case, diagonal ostium, usually with the negative remodeling. So in the case, if you select the balloon size based on the distal part of the diagonal branch, like 2.5 or 3O NC balloon, the diagonal ostium will be severely dissected. So in flow limiting dissection, we cannot do DCB angioplasty. And actually this case, if diagonal ostium was severely dissected and if we switch it to the upfront tooth stenting strategy, the procedure would be very, very difficult because LAD size of the LAD, it was not enough for the elective tooth stenting. And the size of the diagonal branch was not so big. So that's why I used some conservative approach for the lesion preparation.
There is this interesting trend of switching from two-stent strategy to either a hybrid or one-stent strategy. So in my early years as an interventionist, that means between 2016, 2018, the bifurcations will mainly be finished by a two-stent strategy, and I probably did around hundreds of two-stent strategies in a year. And in my fellow time, I did hundreds. But talking with this younger generation of interventionists, Dr. Andi probably did 2 in a year. Yes, and it was a huge trend shift. How about yourself? How was your experience?
Yes, actually I don't use upfront tooth stenting strategy for non-left main bifurcation because almost all non-left main bifurcation the subtended myocardial territory by side branch is usually less than 10% of myocardium. Important side branch is only the circumflex is a very important side branch. So in that case, especially for the complex bifurcation, the definition of complex bifurcation is currently based on definition 2 criteria from China. So for the left main bifurcation, more than 70% stenosis at the circumflex ostium, and the length of the circ-ost disease more than 10 millimeter. That is the definition of complex bifurcation. For the non-left main bifurcation, side branch ostium should be more than 90% stenosis, and the length is more than 10 millimeters. So I think you may be very familiar with the COBIS-2 registry. Yeah. COBIS 1, 2, 3 registry is an all-comers bifurcation PCR registry from Korea. Actually, the incidence of definition 2 criteria-based complex bifurcation in everyday case is only for the 2.3% for the left main, 0.7% for the non-left main bifurcation. So it's very rare. So that means almost all bifurcation PCI can be done provisional approach. And there were 2 opposite trials, DK Croce 6 and the Smart Strategy 2 trial. DK Croce 6 trial used the most conservative approach for the side branch disease. So measure FFR, treat the side branch only for the positive FFR, the most conservative one. Smart Strategy 2 trial from my center used the most aggressive side branch intervention. For example, for the non-left main bifurcation, if the side branch ostium jailed more than 70%, we did IBUS-guided 2 stenting. At 2 years, the DK Croce 6 trial and Smart Strategy 2 trial, the outcome of side branch intervention were totally different. The most aggressive side branch intervention showed the highest event rate. So aggressive side branch intervention is not helpful at all for the patient prognosis because the importance of side branch is very, very limited. As I told you just before, the truly important non-left main bifurcation side branch, the incidence is 0.7%. So based on that, I never used upfront 2 stenting for the non-left main bifurcation. But for the left main bifurcation, if there is complex bifurcation, I prefer to do upfront 2 stenting because there is a higher chance of jailing or losing circumflex, and it is very hard to rescue the totally occluded circumflex disease.
Thank you. We can continue the left main bifurcation discussion later because we have at least two cases of that. Okay, shall we continue, please?
Dr. Wisnu, there's questions from the online audience.
Okay,
from
please.
Dr. Todung.
So Dr. Todung is asking, what is the length of the calcified lesion based on the IFUS? So I cannot remember.
Actually, I could not remember.
Yeah, but it's quite short.
Yeah, it was around 3 millimeter or something. Yeah.
And yeah, we cannot exactly evaluate the thickness of the calcium by IFUS, but I don't think it doesn't look too thick.
Yes, actually, IFUS cannot tell you the thickness of the calcium. But it can show you the arc of the calcium and the length of the calcium. Based on the IBUS criteria, this calcified lesion may require advanced lesion preparation. However, rotahysterectomy, it may not be a good choice because of the severe angulation of the middle to distal LAD. So in those severe angulated region, please avoid rotor ablation because there is a higher chance of the perforation or coronary dissection in that. So in this case, if semi-compliant balloon was not successful, the next choice is non-compliant balloon. And if that is not successful, I would rather to choose the shockwave IVR. It's a very safe device and minimal medial injury. And the lytic balloon, the mechanical IVR, maybe another good choice. Yeah.
Okay, let's go. Let's continue the case. So did a pre-dilatation with 2.5 semi-compliant balloon, then goes straightly 38. Yes, my choice of length. A bit too long.
Yeah, actually, based on the IVUS lesion assessment, the required stent length was around 33 millimeter.
Yes.
But Dr. Vishnu, he preferred to use longer stent.
Yes.
So we should move the stent slightly upward.
Yes.
Yeah.
So that can be the discussion by itself because I was judging by the length of balloon, which we use 2.5 times 20 millimeter, and it almost twice the size of the balloon. But yeah, that's one of the good example on how you cannot accurately judge by just the length of balloon because you cannot evaluate the tortuosity and when the vessel is either facing towards you or moving far away from you, like that. So it demonstrates that the IVUS is more accurate. Please, Dr. Abi.
So I think one of the learning point of this case is that myocardial bridging is mostly underappreciated on angio because we see a significant segment of myocardial bridging in the IVUS, right? So my question is, in this case, with the longer stent, do you stent it into the bridge segment or not? And my second question is, in cases where the bridge segment is not appreciated by angio, but we can visualize it by IVUS, how do we deal with it? I mean, do you still prefer a shorter stent and get out of not touching the bridge segment at all? Or is cases in which the bridge segment is not significant by angio and it is like a coincidental finding by IVUS, is it not that significant for the bridge segment? That's my question. Thank you.
Basically, IVUS is more accurate than angio or your visual assessment. So core registration of IVUS and coronary angiogram is very important. So that's why the education and training is very important. So taking out the IVUS catheter and put the IVUS catheter inside of the coronary artery is not same with the image-guided procedural optimization. So you need to continued training. So I always use IVUS from my fellow. I was taught by this way. So just motorized pullback, no manual pullback. Manual pullback should not be done. It is not helpful at all. Fixed rate, automated pullback is very important. And the simultaneous assess while IVUS is pullbacking, then bookmark your distal stent landing zone, and bookmark your proximal stent landing zone. And after finishing of the pullback, see the longitudinal view together, and select appropriate stent landing zone based on previous bookmark frame, then measure the stent length. And always, myocardial bridging segment is not a best segment to land the stent because it usually with the negative remodeling. So we should avoid unnecessary procedural complication. So for your question, if angio is not so clear for the myocardial breach, but the IVUS showed severe myocardial breaching with the negative remodeling, I would rather to avoid landing the stent at the segment.
Any data or experience? I mean, before IVUS, maybe we put stent on bridge more than we expect, right? Any data or any experience whether in cases in which the angio doesn't show any bridge, but the IVUS show bridge, if we inadvertently put the distal stent on the bridge that is not significant on an angio, does it have a clinical significance? I mean, regarding ISR, stent failure and stuff?
Actually, most cases would be okay. If you didn't do very high pressure inflation, most cases would be okay.
Dr. Madalam.
In this case, did you put the stent on the myocardial bridging or you avoid it?
No, just above the myocardial bridge.
Okay, so probably back one slide back. So another interesting discussion is about the preparation of the side branch and the choose of the DCB. So it was pre-dilated with a 2O balloon, then finished with a 2.5 DCB, then a kissing balloon. So the usual practice in Southeast Asia is usually always aiming at 1:1. You mentioned earlier about how the ostial is often negatively remodeled. I will probably use a 2.5 NC before giving DCB.
NC balloon,
Yes.
Yeah, that can be possible. Yeah, but I prefer to use semi-compliant balloon because NC balloon is more harder to cross the gel side branch, and if that NC balloon stuck with the stent strut, the pushing the balloon will damage to the stent. So that's why I prefer to use the slippery semi-compliant balloon for the side branch access. And if the semi-compliant balloon is not satisfactory, and then we can use NC balloon.
About the side branch preparation, I would like to ask about the rewiring technique that you use for the side branch after stenting. Did you usually check with imaging to make sure that the wire is distally across from the stent to the side branch, or just you have certain technique to make sure that we rewire the distal part of this?
Yeah, yes, I use intravascular imaging for distal cell recrossing only for the left main bifurcation. For non-left main bifurcation, it's very hard to differentiate proximal cell, distal cell, or non-distal cell. It's impossible. Yeah.
Okay, shall we continue? So this is the IVUS result. The comparison between pre-PCI and post-PCI. So sometimes people will suggest to do another intravascular imaging after the dilatation, before the stenting. Do you think it's necessary in this case?
Yes, it can be necessary if you have any doubt about good lesion expansion, especially for heavily calcified lesion, and if you required the LOTA or IVR or something, we need pre-stenting IVUS assessment to check the good stent expansion. But I think in this case, the balloon response was so excellent. So, and I think the pre-stenting IVUS would be helpful, but that IVUS will not change my decision in any way. And actually the procedure field was not so comfortable for me, so I wanted to finish quickly. Yeah, for the patient safety, because the diagonal branch and LED wire keep coming back because of the no flat surface base. So I think without pre-stenting IVUS, the stenting will be successful. Yeah.
That's good. Okay, I think this is the last slide for case number 1. Okay. Oh yeah, this is the RCA. The RCA, yeah, a proximal lesion. Okay, it looks quite a simple one. Okay, now.
Yeah, in the angio, it looks like a type A lesion, but
Yes.
it turns out to be RCA was more calcified lesion.
Yes,
in the
then we
IVUS,
thought.
right?
Yes,
Yeah.
probably we can see the IVUS next. So in your practice or in your hospital's practice in Korea, how many % of patient will have intravascular imaging rather than just straight intervention?
Yes, in Korea, about 40 IVUS intravascular imaging adoption rate in PCI is about 45%.
45%.
Yeah, in my center, it's around 60%, but not for all patients because IVUS has a high medical cost. So basically, I don't think intravascular imaging is needed for all patients. Yeah. Only for the angiographically complex lesion, intravascular imaging will have prognostic meaning.
For us, currently, it's not covered. Yeah, so only a small percentage of patient will have intravascular imaging evaluation. Okay, so we can see there's some calcium, probably around 30 to 40 degree, not really long and severe. Okay, can you please go to the next slide? This proceeds with usual pre-dilatation, and this time we follow the measurement of the IVUS, and this was the final result.
So this was the 4O by the 24 millimeter ultimate Nagomi.
Yeah, that's right.
Next slide, please. The stent was nicely expanded and post-PCI MSA was 8.6. It is quite sufficient for this patient. And based on the excellent expansion and no other suboptimal finding in the post-stenting IVUS, we didn't do any further procedure and finish the procedure. So let's move on to next case.
So case number 2 is left main bifurcation by the main operator by Dr. Todung and Dr. Christopher. So the patient was a male, 57 years old. He has previous cardiovascular intervention in primary PCI in proximal mid LAD and also 1 DAS in the LCX. Echocardiogram shows normal ejection fraction and also normal valves. This was the diagnostic angiogram.
Okay, we can see the ostial LED lesion, obviously, and yeah, we also see an intermediate vessel with the disease and also the circ, which was really not really clear from here whether they had disease or not, but at least it's not critical. Okay, can you please move to the next slide? They did FFR to the. You can see that this looks like a trifurcation lesion. This is the FFR to the circ, and it shows significant number. So DFR, resting base physiology, 0.63, definitely positive then. In Indonesia now, it's really hard to get adenosine. So most of the physiology measurement will be done with resting index.
So using the resting index, the requires some caution because resting index is very vulnerable for the reactive hyperemia. So if you put the pressure wire down to the vessel and measure the DFR and inject the saline, re-measure the DFR, the value will be very different. And after contrast injection, the value will be go further down. Contrast is also partial hyperemic agent. So if you are using resting index, please be sure the flush the guiding catheter with saline and wait sufficient time and until you get the stable DFR value. So DFR, any resting index, IFR, DFR, RFR or something, the measurement variability is very high. So I think using resting index for pre-PCI evaluation is a good practice if you take caution for the measurement variability. However, using resting index in post-PCI assessment, I don't think it's a good approach because post-PCI always reactive hyperemia. So low resting index does not mean residual stenosis.
Okay, let's move on. Do we have Dr. Todung in? Okay, Dr. Todung online
is joining us. Doc.
Good morning, Prof. I'm so sorry. I apologize for being unable to attend.
Yes. Dr. Todung, probably you can tell us the procedure of this patient.
Yes. We face bifurcation for this case. So you can see we must use 8 frames just in case there is a shift plug. If we deleted the ostial LED. So we use 8 frames and 3 wire. Okay, next. This is eye first, from distal LED to left main. The stand is still good, but the proximal until the left main, there is a mixed plug, especially in the proximal LED. So we try first the semi-compliant balloon, but it's slip and cannot stable in the proximal LED. Dr. Yohanes, you have a balloon. The balloon is slid to the left main.
Do you have the image of the
Yeah.
or not?
We have not insert the slippage balloon.
So
okay.
Yeah, okay,
So
that's
the balloon is not stable and not well deployed in the proximal LED. So I decided to use atherectomy IVL lytic that's available in our cath lab. I use 3.5 times 14 and I deploy until 14. Do you have a lytic deployment, Dr. Yohanes?
Probably Dr. Yohanes have not inserted the image, so I think it's only.
Oh, okay.
Okay, we can show it
We can
later,
go
probably from
next.
the system. Yes.
Okay, next. Next, please.
But okay, so yeah, can you play? Oh yeah, it's okay. The media is not compatible. Okay.
I think using lytic balloon for the LED was a very good choice because the semi-compliant balloon was slippery, and the lithic balloon has the multiple element on surface of the balloon, so it is not slippery. So it is a very good choice.
Yes. How was the calcification, Dr. Todung, from the eyes? Was it severe
I
calcified?
think when we try the IFUS, there's only 118 calcification from 5 to 11 o'clock.
Okay.
But when I deployed the semi-compliant balloon, the balloon is slip. That means I think in that part, the calcification is quite high, quite severe, I think.
Yeah. So I saw the image here in my laptop, and it shows your balloon is slipping away.
Yeah. Probably you can see the balloon is slip.
Yes. Yeah, I'm next to Dr. Vishnu, and I just saw the slippery balloon, and after stenting, the IVUS looks very wonderful. And you did kissing balloon with the circumflex using NC balloon, and then final DCB for the circumflex ostium, right?
Right. Right, Prof.
So, Dr. Todung, the DCB was done after the stenting, was it?
Yes.
Okay.
Because in my thought, DCB, I put the CB in the last PCI.
Very good.
Yeah, I think that's a wise choice. So the dilating circumflex ostium with NC and the kissing balloon, and then using the DCB to observe the paclitaxel to the surface of the circumflex ostium is a very straightforward procedure, and it's a wise choice.
Yes.
So there are some discussion about using DCB before implanting stent or after implanting stent. So what do you think about?
You will see a different approach on the fourth case. Yeah, so we can discuss it later on the fourth case, because I did a different approach, that I did DCB first before stenting the left main.
So if that DCB resulted in the very nice result with no dissection error, that can be good choice. But if that DCB resulted in severe dissection of the ostium, that can be problem for the rewiring.
Yes.
So in that case, the only remaining option is the crush technique, right? So
yeah,
I want to ask, what do you think about TAP in this case?
FKB, final. TAP approach, TN protrusion. TAP, yes.
Yeah, TN protrusion.
TN protrusion, sorry.
Yes, I think DCB looks excellent. So I probably not use two stenting for this case, because the circumflex ostium, actually the pre-PCI IVUS, the soc ostium was the site with the most calcification, the concentric calcification. And in that case, implanting TAP stent may be recurrent osteal ISR in the future. And after TAP technique, sometimes it's difficult to do future procedure downstream in the LAD, because TAP resulted in the neocarina. So imagine 2 or 3 years later, mid-LAD ISR, but passing the balloon through the LAD ostium might be difficult because of the protruded circumflex ostium stent.
Okay. Thank you, Bob.
Okay, thanks. Shall we move on to the next case? Okay, so this is the case that you did with Dr. Andy, and I consider this is the most interesting case of the day. So Mr. AGT, 63 years old, stable angina, good kidney function, and good ejection fraction. Probably Dr. Andy can give us some stories about this case.
So we have previously done or did the RCA. So just now we plan for stage 2 LAD. From the previous angio, we know that we are battling against a heavily calcified lesion in the proximal LAD. So, sorry, can you play the right? Cannot. Because from the areocranial view, we can see clearly that there is another problem beside the proximal lesion. It is a very acute angle of the diagonal branch. So our initial strategy is using a 7 French sheet and guide, and then to first to do the IFUS to the LAD. After that, we plan to, okay, can we use only balloon or we need rota? What we didn't expect is even IFUS catheter cannot go across. So Prof. Lee decided to, okay, let's go to proceed rota. We use the 1.5 bar. And the thing that I find interesting is how different we use rota. Usually, the operator in here usually starting from 160 to 180 RPM, but in this way you're using like 180, 190, and then 210. So it's we seldom reach this speed. And then when you did the polishing, you use 160 RPM and slowly. In Singapore, in my fellowship, usually we did the polishing using 140. Yes, slow, but the principle remains the same. So slower speed when polishing. So after we did the rota, we try to advance a small balloon. Or I. Okay.
Actually, this case, we choose the radial 7 French EBU guiding, and the radial artery was not so big enough, so passing the EBU guiding was very difficult. So we used the guide extension, the expressman, to pass the radial artery. So, and the EBU, in my center, the routine EBU guiding size of the EBU is a 3.75. 3.75. Yeah, not 3.5.
I see.
Because most adult men, 3.5 EBU guiding is not enough for the huge support. 3.75 guiding is better. So I felt that 3.5 EBU looks like a little bit small. So if I did this case again, I would change the guiding EBU 4 because the 3.75 was not available. So using the EBU 4 would facilitate the downstream procedure. But anyway, I was in the PCI of the calcified lesion, always the first step is assessing the balloon crossability. Anyway, IVUS did not cross error. That means 2O balloon will not cross error. In the case, we need rota ablation.
If I may ask a bit, you mentioned that to tackle the tortuosity, you did use the guide extension.
Yes. So if guiding catheter stuck in here, then we can use the guiding extension to pass this segment, then move the guiding, pass guiding extension, move the guiding,
okay.
like this.
That's something new for me. Did you use the coronary wire first, or just straightly just the guide extension? Just the guide extension.
The 0.035 inch wire.
Straight over that.
Guiding. If that cannot be crossed, we can the guide extension.
I see.
Yeah.
So this also was the first for me. I offered like using a 2O balloon.
Yes, we usually use a 2O balloon. This is something
to reduce the scissor effect.
Yes.
So they can be rupture the radial artery.
Yeah, yes, that's right. So, but usually the 2O balloon, it will have a smoother outer side. So most of the time it works. Yeah, sometimes you do get a hematoma after that in the brachial area. But this is a
guide
new technique.
extension is more convenient.
Yeah,
more
it's faster. Yes, faster, definitely.
More expensive.
And the rotor ablation, my routine speed is always 190.
190.
Yeah.
The faster.
If that cannot pass, 200. Yeah. If that cannot pass, step down the rotor ball size 1.25, and after the passing the burr, I size up the rotor, and after passing the region, I do the high speed polishing and then slow speed polishing. Yeah, that's my routine protocol.
Okay.
But yesterday you asked me to stabilize the guide catheter while you do the ablation.
Yeah.
So you manually push it?
No,
or?
I just maintain the guide catheter.
Oh, you just hold it?
Yeah, just hold.
Yeah, because if you 3.5 was the supporting was so weak, and whenever I try to pass the rotor ball, guiding catheter keep coming back. So that's why I asked you holding the guiding catheter. Yeah, sometimes it can be very helpful. Yeah.
So after we did the rota, if I remember correctly, we tried to.
Next slide, please.
Oh yeah.
Next.
Can go to the next slide.
Ya,
Oh,
ini sekarang yang mana?
So anyway, image is not working. So after patching the rotor ablation, then actually we did side branch wire.
Yeah.
Right? Yeah. So using the Fielder XT wire and the Corsair microcatheter, we did diagonal wiring and then switch the Fielder XT into the workhorse wire. And then we used the guide extension and 1.5 millimeter balloon.
Probably, if you don't mind, can you draw it for us? Because the angulation is very steep that I thought you were going to use a reverse wiring technique.
Yes, actually not exactly same with the reverse wire, but I did some very huge shaping.
Huge bend.
Yeah.
With a very sharp, small bend.
Okay, let's move this. Let's use this board instead.
So maybe Andy, you can show us how to do hairpin technique.
Yeah, I believe it's the shape is something like this, the diagonal.
Yeah. So,
Jatuh.
so you want to explain the first hairpin first, or the one that you did yesterday? Which one you want for me to explain first? The one that you did yesterday, or the?
Yeah, your way, your routine way. Yeah.
So usually, outside we have the introduction, right? Let's say this is the introduction. So usually the wire, I bend it here and then make a curve like this. So I just inserted the like this to the wire connector, and then so when I expand the wire
It will be shaped.
will be shaped like this.
Yes.
So I just push forward after crossing the diagonal, and then pull back, trying to make this small tip to engage here.
Yes. So probably we should.
That's a hairpin technique,
Yeah.
right?
So probably we should draw. If this is the guide. Let's say this is the Y connector. The Y connector. This will be the Y connector. And then you want to. This is the introduction sheet. And how will you insert the wire to the introductory sheet?
So the wire is already like this.
Yes, exactly.
Yeah. So
Yes.
it's insert like this.
Yes. So the wire, when it's inserted, the wire is not inside the introductory sheet, but rather going out and already shaped, have like a hook shape inside. Yeah, this is the classic hairpin technique. And what did you do yesterday?
Yeah, actually, basically it's very similar, very similar. But Andy used the introducer sheet in here, but I use micro catheter instead of the introducer sheet. So that's facilitate after hairpin wire go into the diagonal branch, we can just put the micro catheter through the side branch wire and rapidly exchange it into the workhorse wire. That's more convenient.
Yeah, that's a nice technique.
Yeah, and yesterday I actually used my way was not the exactly same with the hairpin technique. I just shaped the wire like this, and this is Corsair micro catheter, and after tip of my wire into the diagonal branch, I slightly moved the Corsair micro catheter in here and rotate the wire, just go into the diagonal branch. That's why I use the Fielder XTR, very flexible wire.
I see.
Yeah.
So how did you introduce the microcatheter inside the Y connector? Was the wire inside or outside of the microcatheter when you put it in the Y connector?
Wire inside the microcatheter.
Still inside the microcatheter.
And this one to the Y connector.
I see.
And after at this point, push the wire and then engage the side branch. And then move the microcatheter along the wire,
Okay.
then rotate the wire.
So, but different than the hairpin technique that Andy mentioned, that it was in the when the introductory needle was put, the wire was outside, but you put it inside the microcatheter first. You shape it, then you put it inside.
Yeah, actually,
Okay.
hairpin technique can be done using the microcatheter.
Yes, so it's outside also.
Yes, and it's more convenient to exchange the wire.
Okay, very nice.
Yesterday you asked to change the microcatheter. So initially we used
Yes.
cross and then opt to course.
Yeah, actually, I don't like fine cross because in the fine cross has a lowest crossing profile. However, at the tip of the fine cross, there is a small metal ring.
I see.
That metal ring sometimes stuck with the calcified nodule or calcium plate, but the Corsair or Caravelle, the tip is a tapered tip.
Yes, yes.
So it's a very smooth. So I always much prefer to use Caravelle or Corsair Pro XS Small. There are two types of Corsair: Corsair Pro and Pro XS Small. Yeah.
Can you shape the micro a bit? Just shape it a bit manually.
Microcatheter
Yes.
shaping.
Uh-huh.
Don't do that. Yeah. Don't try to shape microcatheter. Yeah. And if you need some angled
Angulation,
microcatheter, you can use Supercross.
Yes. Okay,
But
with different angles.
Supercross is not so good for passing the region.
Okay. I know my friend, an interventionist friend who always use Supercross. Yes, for angulated lesion. Okay, so yeah.
So one more thing, the Caravelle and Corsair, if you try to advance the hard region, Corsair Pro can be rotated clockwise. That can facilitate across the region, but Caravelle don't rotate. Rotating the Caravelle microcatheter will break the tip when you do the calcified region CTU. Yeah.
So after roughly managed to wire the diagonal, we just proceed with pre-dilatation. We're using the semi-compliant 1.5 first because if I remember correctly, even after rotablation, I first still cannot go across. So we opt for a very small balloon. We started with 1.5 first, and then after using the 1.5 and then using the Guidezilla extension, we managed to deliver the IFUS. So after that, we see that there's a very, can you play the IFUS? So in the IFUS, okay. So from the IFUS, we see this is a very calcific lesion. It's long and diffuse and 360 degrees. So the length itself is more than 5 millimeters. So, but we get the distal reference is 3.0 and the proximal is 3.5. So after using the 1.5 balloon and then using the in-swarming technique to advance the guide Zilla, and then we start to use the 3.0 NC. And then we actually got one image where we see that the waist, when we expand the balloon initially, so we have one image where we expand the balloon, there is some waste, but when we inflate or when we increase the pressure more, the waste suddenly pops. So roughly as to, like,
yeah, sometimes the loading is not good. Probably better there. Okay, can you move to the next image? Is it movable? It's okay. Yeah. So probably for people who's not really familiar with inchworming technique, you can explain further.
So basically, when we try to push the guide catheters, the guide extension, sometimes it stuck against the lesion or even can be stuck against the stent. So to properly advance it, we just inflate a balloon in front of the guide extension, and then when we deflate, we push the guide extension.
Did you inflate it halfway with the half balloon inside the guide catheter, or just completely outside?
No, completely outside.
Completely outside.
Yeah. So that's inch warming technique is very useful to do this kind of lesion. So after that can be used after implanting the stent, because the proximal edge of the stent guide extension can be stuck with the stent strut. In that case, there's just small balloon, 2.5, and the outside of the guide extension catheter, nominal pressure inflation, and deflate and simultaneously push the guide extension. So that's very smoothly go inside the vessel.
When you did that, were you already wired the diagonal branch or before that?
Yes, all those procedures done after diagonal branch wiring.
After diagonal branch wiring, it can be really tricky with 2 wires, one in the branch and one in the...
Actually, diagonal branch wire were outside the guide extension.
Yes, okay.
Yeah, because we are using the 7 branch guiding, that can be done. So diagonal branch wire, LED wire, the guide extension were also the only for the LED wire. 6 branch guide extension. Okay. Yeah. So if you are using 7 branch guiding, 2 wire, you can use like that. So guide extension only through the 1 wire. Yeah.
I've had difficult scenarios using in this type of situation, even when I'm using 7th branch, but it has lots of tortuosity on the brachial and the subclavian side. So sometimes it gets stuck too, even when you're using 7th branch and 6th branch guide extension. Have you ever experienced those kind of situations?
Yes, in severely tortuous the subclavian artery, that can be possible. That's why I prefer to use launcher guiding.
I see.
So if you are using Terumo or Asahi Hyperion, XB, those guiding catheter, or the body of the guiding catheter is very flexible. So in tortuous subclavian artery, the huge resistance in here. But the Mediterranean launcher guiding, it's very hard. So when I was fellow, some of the staff in the Seoul National University, he used to hit me with that guiding. It's very painful. XB or Terumo, it's not a problem at all. But launcher guiding, it's very painful.
Okay, so please, Dr. Andy, probably you can explain.
So this one.
So this one, you have the guiding, but you have not yet the D1, or already finished with the D1.
Oh, I think this one finished already.
This one is finished already. Yeah, this one.
So after we pre-dilate the lesion with the 3.0, we see that actually the 3.0 expanded quite well. We did a repeat IFUS. We see still we see some cracks, some reverberations, but there's still some protruding calcium nodule in the IFUS. So we decided that before we plant the stent, we need to do something more. Initially, Prof want to use the cutting balloon.
Yes, probably. Can you go back to the previous steps so we can see after the rota? What did you do after the rota? Mungkin a bit before that. Yeah. These steps. Okay. These steps.
We decide to use lytic balloon, right?
And the interesting thing is when Prof tried to deliver the lytic balloon with the guide sila still inside, the lytic balloon cannot go. So we remove the guide sila and then try to advance the lytic balloon and then just go smoothly.
Okay.
So in the 6-branch guide extension, 3O lytic balloon cannot go inside.
Yeah, cannot go.
So we remove the guide extension, but the lytic balloon, the crossability was excellent.
Okay.
So I was so surprised that it go very smoothly, and we did the lytic balloon angioplasty, and then implanted the stent based on the IVUS measurement.
Somebody is smiling behind it.
So after we...
what happened? Why did you cannot trust with the guide extension, but you can do that after you remove the guide extension?
I think the balloon is stuck against the proximal part of the
I see. Okay.
extension.
Maybe the crossing profile is the lytic balloon is bigger than guide extension.
Yes, okay, understand.
So after we pre-dilate all the lesion with the lytic balloon, we decided that it's time to stent. Initially, we planned for a 3038 stent, but because no size is only the Tansei, we want Nagomi, right? So we up to 3044 millimeter.
Sure.
6 millimeter longer, but it's still
so
very well.
In this kind of situation, is Nagomi Tansei and Ultimasa Tansei and Nagomi different that much? What do you think?
Yes, I think so. Nagomi is much better for the crossing profile, and it's such kind of region. Nagomi is much better than Tansei. Actually, to me, there are two best stand for the crossability. One is Ultimate Nagomi. Second one is Onyx Frontier from Medtronic. Those two stand has a best pushability and best crossability in any type of the region. So if you have both Nagomi and Tansei, please use Nagomi for the very complex region. But the simple region, you can use Tansei.
Sure. So after this session, probably we can ask our friends from Thermo to present again about the specification of the stent, because some of us haven't heard it because we did the live case and also we have 2 sessions yesterday. Okay, please.
So after we implant the stent, probably pull a bit the balloon and then inflate again to I think 16 ATM, and then after that we decided to repeat IFUS. So actually nggak bisa dipunya.
IFUS bisa bolak-balik.
Yaudah, okay. So the final IFUS showed that the stent good. Wait,
good.
Nggak bisa dia.
So this is the part of the stenting.
Can you play the IFUS?
Okay.
Okay lah.
Did you do IFUS before the stenting or after the stenting?
After.
After the stenting. So okay, let's continue with the stenting first. Okay, yes, move to the stenting part.
Yeah, so this is the stenting part, and then after that we post-dilate some more with the same balloon, but we pull back a bit and then go higher pressure to 16 ATM.
Okay.
And then we repeat the IFUS. We saw that the no stent is dissection, and throughout the stent it's expanded very well. But there's one small problem. That's in the proximal landing zone. There's some areas of malapposition. But yesterday, Prof. Lee said that the length of the apposition is less than 3 millimeters, so it's minor. And then we saw from the IFUS the longitudinal view that it's like uniformly large, so we decided to leave it alone.
Okay. So the interesting part of doing cardiac intervention is how many different in details that sometimes the operators did. So for example, we were trained in different centers. Me and Andy probably in Singapore, some of us in Indonesia, Abirama from China and so on. And one of our interventions was trained in Brunei. And they never did just pull the balloon a bit, the stand balloon a bit and expand again. It always finish up with an NC. So because the theory was to avoid proximal stand edge dissection. So yeah, what do you think about that?
Yeah, actually, we are doing the IBUS guided procedure. We already know that the proximal stent landing zone has a very, very minimal plaque burden. So that's why we implanted on the target segment and then high pressure inflation and then slightly move the stent balloon and another high pressure inflation for the good proximal opposition. Because IBUS already showed minimal plaque burden at the proximal edge of the stent, the risk of proximal edge dissection would be minimal, as you can see in this patient. Yeah.
Okay, that's good.
There's a question from Dr. Todung, Dr. Wisnu.
Yeah.
Why not use 1.75 or 2.0
okay.
later?
Yes.
Yeah, we were using 7 French guiding, so 1.75 per would be only the next choice. But based on the unstable guiding position, because as I told you before, EBU 3.5 is a little bit shorter than required. So 1.75 millimeter rotor ablation. I thought it would be very difficult to pass the region based on the limited guiding support. And I didn't want Andy or expose so much radiation due to holding the guiding, because just next to the cine arm, so I didn't like it. So we just proceed the next procedure.
You already got 2 kids, Andy. Oh, 3. Oh, yeah. Just a newborn, right? Yes.
So if I were using EBU4 guiding and good guiding support, my next choice would be the using 1.75 millimeter bar. Yeah.
Yeah, please, Dr. Matalam.
Congratulations for this very, very interesting case. But I have a question, Dr. Lee. What is the prediction of restenosis on this kind of patient? Restenosis late. This is very extensive.
Yes, yeah, actually, do you know Renovate Complex PCI trial? They published it 2023 in New England Journal of Medicine. The Renovate Complex PCI trial, a randomized trial done by my center, were randomized intravascular imaging guided PCI or angiography guided PCI for those type of complex lesion. The definition of complex lesion was left main CTO, heavily calcification, ISR, diffuse long multivessel intervention, or osteal intervention. So during the median follow-up of 2.1 year, the target vessel failure rate in the image-guided PCI was 7.4%. Angiography-guided PCI group, 12.5%. So I'm expecting after 2 years, around 7% of the target vessel failure rate can be observed for those type of complex lesions.
Okay, shall we move on?
So we proceed to the final case.
Very, very nice result. This
by
case.
Dr. Wisnu and Dr. Madatila, the left main lesion. So these are the cases. Female, 64-year-old, has a history of hypertension. The echo shows normal ejection fraction and concentric left ventricular hypertrophy.
Okay, so probably Dr. Madatila can walk us through with this case.
In this case, as we see from the coronary angiography, especially from the spider view, we can see that the angulation from the left main to the ostial lesion is very, very stiff. And we have trifurcation, intermediate lesion, and also LCX, but the LCX seems quite healthy. So based on this image, we can see that our obstacle in this kind of tortuosity, and because and also the position of the lesion, as we can appreciate that at the distal of the left main is quite healthy. So the lesion is at the ostial of the LAD to the proximal, and also at the ostial of the intermediate to the proximal. So we decided to do the imaging for this lesion first to appreciate the lesion at the intermediate and also the LAD. The next slide, please. And this is the IVUS from the LAD. The distal, the minimal main area is quite tight, it's around 2.2 calcified lesion, but it's quite superficial and short lesion, so we assume that we can manage this lesion with a balloon, like scoring balloon. But maybe, as Prof. Lee mentioned at the beginning of this session, maybe we can use semi-compliance balloon first, but maybe we can discuss later. And the intermediate lesion, we can see that from the distal lesion, the size of the vessel is around 3.3, but the ostial is 2.75. So there's a negative remodeling at the ostial of the intermediate. As Dr. Lee also mentioned at the beginning, that it could happen in the side branch. Okay, please, next.
So I tend to use a modifying balloon, like scoring or cutting, if you find a really thick fibrous in this case. So that would be my first choice. Rather than just using SC or NC, then you just pushing everything apart, then the risk of perforation or dissection is higher.
Based on we can see positive remodeling in the intermediate branch. The plaque burden is very, very high, even though the plaque characteristic based in IVUS, the posterior attenuating plaque, meaning the highly lipidic plaque. However, in this intermediate branch, mostly fibrous plaque.
Yeah.
So in the case, I also prefer to use scoring balloon, because if we use NC balloon, that NC balloon will cause severe dissection between the plaque and normal segment, the transition point of the intima. So control the dissection using scoring balloon will be the wise choice.
Okay, thank you, Prof. Next, and the next step, we decided to use the scoring NC balloon for the ostial of the LAD.
Would you like to show the DICOM?
Yeah. Oh yeah, another thing, wiring through this tortuosity.
The wiring was difficult because it was quite tortuous and the angulation was tight. So we use run through NS. So the wire works quite well. Also the guiding was really unstable because we got lots of tortuosity. So in this case, we prefer to finish the procedure as quick as possible to avoid guiding complication.
From the IVUS evaluation of the ostial LAD, we appreciate that the diameter of the vessel of the ostial LAD is 3.5, and Dr. Wisnu decided to use 3.5.
So the diameter of the proximal LAD was 3.5.
Yeah.
That's right. But the left main was huge. It's about 4.5.
4.5. Yeah.
So this is the score flex. We started with 3.0.
3.0 to nominal.
Yeah, to nominal, because
and
the distal part of the LAD was
is 3.0. And let's see the next slide after the balloon. We found a quite significant dissection.
You can see significant dissection there.
Or do you have any insight for this? Or should we start from the lower size of the balloon?
I'm sorry, the diameter of the proximal part of LED was 3.0, but the left main was huge at 4.5. So this one was Scoreflex 3.0 times 15 millimeter, Scoreflex NC. Any comment?
What was the plan for the intermediate branch?
So, initially, we always keep our options open. The first choice is ideally to have a hybrid procedure if possible, but we are not limiting our strategy to just one strategy. If it's open nicely with a dissection, we can continue with the DCB. But if it has significant dissection, we are still open to do stenting, either a TAP or a complex upfront too. Everything's open. But the problem is the diameter of the intermediate is a bit small, about 2.75. So if we have to do two stent strategy, probably a TAP, a TAP probably.
Yes, actually, if that pre-dilatation for the intermediate resulted in this very, very severe dissection, and you had to switch to the two stenting strategy, TN protrusion would be very difficult because after putting the main to LED stent, you should rewire through the dissected intermediate branch. So if that wire go into the false lumen, you will lose the intermediate branch. So in the case, so after region preparation for the intermediate branch and it resulted in very severe flow limiting dissection, I would rather to choose Culo technique. So main to intermediate stent first, and then rewiring through the LED, and then kissing balloon, and then main to LED stent, and then second kissing balloon.
The thing is, it's okay to change strategies as we go through. So actually looking at the angio before the procedure, the initial thought was, it's probably we can do ostial and ostial. Ostial and ostial, sorry, yes. Because the angulation is quite safe. It's the more steep angulation you have, then the less chance that the carina will shift and push the other. But as we go through, we measure up and did a pre-dilatation and having this dissection, then we have to think about either a hybrid or an exit strategy, because after we have this dissection, then it was decided that we will do a left main stenting. So now it's a matter of what you want to do with the intermediate. Then we tried to pre-dilate the intermediate first.
Yeah.
What was the size of balloon that we chose? 2.5 initially.
Because the vessel was about 2.75.
Yes.
And we learned from the first LED.
Yes.
We didn't want to get that kind of dissection in the intermediate, so we decided to take a smaller balloon.
Yes. So
with a very gentle expansion.
Yes.
Yeah, it looks like very nice result for intermediate branch.
Yes. So will you lift this with a 2.5? We dilated with 2.5 Scoreflex NC. Will you be satisfied with this, or will you do a bit further up?
Yes, I will satisfied with this result, because if I try further and dissection happen based on the severe LED ostial dissection, that will make procedure very, very complex.
Yes, exactly.
Yeah.
So can you please continue?
But we try to continue.
But yeah, we discussed it.
Yes.
We try to be a little bit bolder, take
so we
a little more risk.
0.75 scoring.
Yeah, so we upsize a bit.
Yeah, I see very interesting comment. Free stenting could be considered.
Yes.
Are you still using free stenting?
Not as a template, but in a very emergency and feeding situation, I probably did 2 or 3 free stenting the whole of my 10 years career. So it was an emergency, osteum. Okay, you just did free stenting. The patient was unstable, then finish. Sometimes you as an exit strategy.
Yeah, actually, based on COVID-2 and 3 data, when we compare prognosis among the different 2 stenting technique, no different at all. However, only the free stenting is the worst technique. So after putting the free stent, if that restenosis recur, it is almost impossible to do any procedure downstream. So we no longer use free stenting anymore.
Okay, please, Dr. Madhu.
And we decided to move forward. We escalate the balloon to 2.75 scoring balloon at the intermediate, and the result is quite good. And we proceed to stenting to left main LAD. The diameter of the LAD was about 3.0, and the diameter of the left main was 4.5. And we are lucky that we are using Nagomi, and Nagomi can escalate from 3.0 to 4.5. And please, the next slide, please.
This is
the DCB first.
Yeah,
Okay.
so this is the discussion. DCB first, in this case. And also, we're borrowing your technique from the first case. So this is a very nice, simple step that when you're doing a DCB, try to inject the contrast, make sure it doesn't block the other vessel.
Sure.
I love this technique, and I will steal it from you.
Yeah, sure, anytime. I learned this technique from Professor Hyosu Kim, Seoul National University. Maybe Dr. Todung very familiar with. So all those procedures are just in sequence. So prepare DCB, go into the guiding catheter, test and DCB, locate the DCB and inflate and inject the contrast to check the main vessel flow is okay. So this is one sequence. Yeah. The fundamental reason is to maintain at least 60 seconds of total inflation time for DCB. If the DCB is blocking left main to LAD flow, we cannot maintain 60 seconds, right?
Thank you, Prof. Lee. And after DCB, next slide, please. Next. We put the DCB for 60 seconds. Okay, and after DCB, the flow at the intermediate is very good. There's no severe dissection. Even we didn't see any dissection at the intermediate, so we proceed to the next step, stenting from left main to LAD using Nagomi stent 3.0. Next, and we make sure before taking the size of the stent, we make sure that the balloon for POT that we have from the IFUS, we have like 8 millimeters balloon, 4.5.
So from the IFUS, the measurement is about, the length of the lesion is about 3 centimeters, 30 millimeters. But intentionally choose a bit longer so you have more space for POT in the left main. Yes.
Okay, next.
The guide was largely unstable, so this was a big issue. If you don't handle it correctly, it will crush the stent from the proximal.
Next. Next, we inflated the balloon. And we only one inflation with nominal. And this is a very crucial part when we take out the balloon of the stent, and we have to make sure that the guiding not crush the
okay. Next.
The stent. Next. Next. Okay, this is the 4.58 balloon for
Yes.
POT.
So straightly POT. Yeah, just to secure the proximal part.
Okay, next.
With the
And-
diagonal wire still jailed. Yes. The intermediate wire. Okay.
Next, and after ballooning, after POT, we make sure about the expansion and also the optimal POT with a stand boost to make sure the stand boost.
Yeah, doing part is very important. In case you don't do final kissing balloon. So if you did final kissing balloon, the additional part don't have prognostic benefit. However, if you didn't do final kissing balloon, part is essential to improve patient prognosis. There is one paper from COVID-3 registry. So the evaluated prognostic impact of the proximal optimization technique. Part was better than no part in patient without kissing balloon, final kissing balloon implantation. Yeah.
So you can see from the stand boost or stand fist in GE system that the Nagomi stand expand nicely to 4.5 compared to the distal in 3.0.
So Nagomi is very good stand because it has very wide expansion range. So even though 3.0 Nagomi expanded up to 4.5, the connector between the stand strut is well maintained. But the previous version of the other stand, if you do too much expansion, all that connectors are broke and the polymers are break. So that is source of the restenosis. So that is the superiority of the ultimate Nagomi.
And the right part, the IVUS after pod, the MSA was about 7.5 actually. And the left main is 13. The stand will oppose, well expanded, and we take off the wire from the intermediate, and we didn't do another things anymore. We didn't rewire and not doing casing and POT.
So what I did usually was I took off the wire, then I repot just to make sure that the stand was re-expanded, then final IFUS. Did not do any recrossing or stand strut opening. Just leave it like that. Some operators did use a very short balloon just to open the strut sometimes, but usually I just leave it alone if I choose to do DCB first.
Yeah, that's a wide choice. I do same way. Yeah.
But is it because of the intermediate is not a very big one? If we
actually it is not because we already did DCB angioplasty for the side branch, and recrossing any wire can damage it to that vessel, and that is unnecessary risk because the expansion is wonderful. So just taking the part and check the angio, if that is okay, finish the procedure is a wise choice. And there is no supporting evidence opening the side cell after provisional stenting. No supporting evidence at all. But the European guys, they always keep saying that opening the side cell is mandatory, but Korea, Japan, we never do. And actually, the prognosis of our patient is much better than European patient.
Thank you, Prof. Lee.
What is your angiographic view of choice when you do left main pot? Spider or this is epicranial, epicaudal?
Actually, I don't have I don't have my routine view. I just follow my radiology technician provide. Yeah. So actually, Samsung Medical Center, my team is consisted with the very highly efficient radiology technician and nurse. the 2 RT and 1 nurse, and me and fellow are one team. So I just follow recommendation from my RT.
In our hospital, usually the scrub nurses are very versatile. They're doing everything. So we don't have a specialized radiographer controlling the cath lab. It's all done by scrub nurse.
Yeah, only one thing, I don't like spider view because radiation exposure, I don't like it. So spider view is very, very dangerous. Or cranial view, very dangerous. So I don't like it.
Is this the last slide?
Yes.
Okay.
Last case.
Yeah, please, Dr. Andi.
Regarding the scoring balloon that you use for preparing the lesion, in Indonesia, as far as I know, the only available was Scoreflex NC. It is an NC balloon, so higher pressure. But I believe in other countries there is available scoring balloon with lower nominal pressure. What do you think the difference between two types of scoring balloon? Will it affect the dissection rate? Thank you.
Yeah, I think they each have strengths and weakness. So in Korea, we have scoring balloon with semi-compliant feature, angio score. And the strength of angio score is a wide expansion range. But the scoring balloon based on non-compliant balloon, it is also have a strength. If you choose 1-to-1 size, NC and scoring balloon, that can be wonderful for any type of the region. So I don't think it's a huge matter. Each balloon has its own strengths and weakness, and you can choose depend on the situation.
For this kind of lesion, can we, for example, inflate in lower nominal, maybe only 6 or 8 ATM with Scoreflex NC to avoid dissection?
Yes, I think it's a wise choice. Yeah, if ramus intermedius resulted in severe dissection, all procedure can be very complex, right?
I have a questions regarding this case. So after you perform the scoring balloon in the main vessel, you have a significant dissection, and from the angio it looks like an intramural hematoma. Do you perform IVUS after you score the main vessel before DCB to the intermediate? I mean, my concern is if we do a DCB intervention to the ramus, and then if there is a significant hematoma and we put a stent in the main vessel, sometimes the stent can push the hematoma to the distal and the proximal edge, right? I mean, do you have any experience of whether it has a significant risk to close the side branch, and we have to maybe secure the side branch with stent first in this case?
So in this case, the main concern is the unstable guiding, and you can see that the wire is really difficult to reach the distal because it's keep at the acute bending in the LAD, it keeps going through the small vessel. So therefore you don't have enough support. So if you can do that, of course, theoretically you do the IVUS to LAD first, you do IVUS to intermediate first, but you will risk the guiding become more unstable and at some point probably losing its support or everything is just come out apart. So as a technician, it means somebody who's doing it technically, then sometimes you have to choose the practical way to finish the case safely and quickly before something bad happen. So those steps, if you feel that the LAD is already well open, then you just stand it and look for the result later, and if something bad happened, you probably can fix it later. And in this case, because everything went well, you don't have any complication, then you can just finish it quickly.
Dr. Wisnu, I want to ask, regarding the guiding catheter, is it possible to stabilize the guiding to put one more wire to the aorta?
Actually, we did. Not in the aorta, because you also need, because if you put the wire in aorta, then the guiding could not engage, then you will lose lots of support. But we did, when we pull out the diagonal wire, tail diagonal wire, and before we take out the 4.5 balloon, we did put the wire in the aorta, just to make it safe that the guide will not crush the stent from the outside. Yeah. So I think we've done the case series. Thank you, everybody, for discussing such an interesting discussion. So next we would love to invite the speaker from Terumo to present, to tell us about the Nagomi stent.
So, good morning, everyone. Thank you, Dr. Wisnu and Prof. Lee and all the distinguished doctor for inviting us for the second presentations in this event. So, this is our new tagline, when every decision matters. So this is will resonate more into the presentation later on. So we are here to support every step of the PCI journey. My name is Febrina. Along with me, we present Pak Lively Yosef as the business manager, and then we have Pak Anggo as the sales manager, and Mbak Ajeng as a sales manager as well, and Pungki is from our distributor, MBS. And before we are going to the Nagomi, what we actually can support for interventional cardiologists is from access to hemostasis or closure. So we have the introducer seat. Maybe yesterday our glide seat slender also used during the cases. We have the navigation system like wire, catheter diagnostic, as well as the guiding catheter. We also have the lesion crossing and preparation like balloon, fine cross run through, and we have the delivery treatment like stent, and the one that we gonna go through, Nagomi, and the last one will be the hemostasis, TR band, as well as angioseal for the femoral closure device. Next. So what we are going to be highlighting today is the Ultimaster Nagomi. Nagomi actually meaning heartwarming or calm. Next. So Ultimaster Nagomi is actually the latest generations of the Ultimaster DAS, which hopefully can bring excellent deliverability with larger size lineup and even greater over expansions capability. So currently in Indonesia, we have Tanse as well as Nagomi, which the first journey for Nagomi is starting yesterday. Thank you to Dr. Wisnu and all the Jakarta Heart Center team for letting us to smoothly soft launch this Nagomi. So with Ultimaster Nagomi, actually there are several design that has been improved from the previous Ultimaster. First is the 3 platforms specifically designed to meet the needs of each vessel size. The second will be the largest size lineup. In total, we have 88 SKUs. So the new is 2.0 diameter and 4.5 diameter, which the length will be 44 up to 50 millimeter. And the third one will be the optimized overexpansion capability up to 6.25. This is for the 3.5 and up to 4.5 diameter of the DAS. and the new hydrophilic coating for the enhancement deliverability and building on the heritage of strong clinical evidence of the Ultimaster family. So, next. So where does the new design actually give us something useful during PCI? And that is how I would like to walk through the Nagomi today. So, as we mentioned, it is an evolution of the platform with some specific design changes intended to address different vessel sizes and some of the challenges we see in the contemporary PCI. And this is particularly interesting because the platform is now designed around 3 vessel size category: small vessel, which 2 to 2.5 millimeters, the inherited medium vessels from the last Ultimaster, 2.75 to 3 millimeter, and the new is for large vessels, which 3.5 to 4.5 millimeter. And for the long lesions, we provide the 44 up to 50 millimeters, as we can see here. Next. So for 2 to 2.5 millimeter vessels, Nagomi introduces a dedicated small vessel design with modification to the strut and band dimension to improve the flexibility. So we can see the band is actually 80 micron as well. For medium vessel design, it will be 90 micron, and for the large vessel design, it will be 120 micron. In terms of the struts, all Nagomi is coming with 80 micron. As we can see here, so we actually, the internal bench testing shows that there is an increase in flexibility up to 14% from Ultimaster Tansei. And when we are dealing with the small and sometimes tortoise vessel, we want the stent to be able to follow the anatomy without unnecessarily compromising deliverability and conformability. So in terms of the links, Nagomi used the same links as Ultimaster Tansei, which is 2 links. But in terms of the crowns, the improvement is coming from the new large vessels that is using 10 crowns. Next. So yes, then we move to the other end of the spectrum now for the large vessels. So we may need to think about the expansions, position, and particularly what happens when the vessel or the bifurcation requires us to go beyond the nominal stance. That is why Nagomi introduced a 10 crown design for 3.5 to 4.5 millimeter platforms with an expansion capability up to 6.25 millimeters. And I think this is where the design becomes particularly relevant for the cases involving large vessels or bifurcations. Next. So this is how it shows during the bench testing from the stent 3.5, 4.0, and 4.5 when we expand the stent diameter up to 6.25. This is how it looks like for the stent struts. Next. And the new 10 crown designs actually increase the cell area by 10.5% to ensure better apposition even in a large bifurcation, including the left main, and allows a more uniform vessel coverage compared to an 8 crown design. And if we can see here a stent design from Nagomi versus Tansei, the cell length is actually increased 1 mm, the cell diameter increased 0.3 mm, and the cell area increased like 3.8 mm. Combined, it increased 10.5% of the total cell area versus Tansei. Next. So now another area that I think is worth looking at is the deliverability. I think this is also relevant during yesterday cases. So we all know that once the lesion becomes tortuous or the support is not ideal, the difference between a device that can cross and a device that crosses smoothly can become quite meaningful. So Nagomi incorporates a new hydrophilic coating and changes to delivery system. In internal testing, this resulted in a 45% reduction in sliding resistance compared with Tansei. So I think this is one of those specifications that becomes more meaningful when you translate it into the cat lab environments. Make the device easier to get where you want it go. So this is actually the ultimate objective of the new hydrophilic coating. Next. In terms of the balloon, this is also one of the improvement that Nagomi has. So we incorporate new balloon with a nominal pressure of 11 atmosphere with rated burst pressure 16 atm. So previously the balloon for Tansei using 9 nominal pressure. In Nagomi, the catheter inner lumen also increased, and the objective is to actually faster deflation time, and this is very useful when we use the longer stent length. Next. And from the drug and polymer perspective, Nagomi retains the core Ultimaster philosophy. It uses an luminal gradient coating with sirolimus with the polymer design around short-term exposure and vascular healing. So we, as we previously showed, the platform used 80 micron cobalt chromium for the optimal conformability. And also we use bioresorbable drug coating applied in gradient and short-term polymer exposure. Next. So this is how it looks like. The difference between the gradient coating when no drug polymer coating on parts of the stent that experience the most physical stress. This is mostly helpful during the overexpansions of the stent. Next. And in terms of the comparative with the circumferential coating, the Ultimaster Dash family of luminal gradient coating shows that there is maximal endothelial coverage in 2 weeks. So the coverage shows almost 97% compared to the circumferential coating, which only 73%. Next. So with this, I think this part is important when we introduce any new DES. So new generation should not meaning starting from zero. Nagomi builds on the clinical experience and evidence accumulated across the Ultimaster family. The program has included more than 50,000 patients with data from randomized trial as well as real-world registries and more complex patients. Next. Yeah, so the story is really one of evolution and established clinical foundation with a platform designed to give the operator more flexibility around the anatomy. So in terms of the clinical evidence, we divided into 3, which shows the result on the optimal vascular repair through discovery 1 to 3, which shows 1 month strat coverage 85%. And the second one is long-term safety and efficacy in randomized controlled trial mirrored in real-world clinical practice, both Century 2 and E-Ultimaster trial. The results shows low rates of target lesion failure and stent thrombosis at both 1 year and 5 year follow-up, covering multiple indications. And the last one is 1 month DIPT in high bleeding risk patients with master DIPT. The results show that RCT showing reduced bleeding events with 1 month versus standard DIPT. And perhaps that is the way I would summarize Nagomi. I don't think we need another desk simply because it is new. What is valuable is when a new generation gives us something that is relevant when the case becomes challenging. Small vessel, large vessel, bifurcation, tartus lesions, difficult delivery. And different situations require different consideration. So rather than asking whether Nagomi should replace what you are already comfortable with, perhaps the more relevant question is, in which patients or anatomies would this additional design capabilities actually make a difference to the PCI? And I think that is where Nagomi becomes an interesting option to consider. So ultimately, the device is only one part of the procedure. The important thing is giving the operator the right options when the anatomy demands them. So thank you.
So probably you can share your experience with Nagomi so far in Korea. What is your opinion about this stand?
Yes, actually the modern drug-eluting stand are all good, yeah. But the strength of the Nagomi is the crossability and availability of 50 millimeter in length. Personally, I love Ultimate Nagomi and the Onyx Frontier for the very, very complex region. Those two stands are much better than the Giants or Synergy or other stand.
Okay, once again, thank you very much to Dr. Edwin that has been already discussed yesterday's cases, and thank you also for the moderator, Prof. Lee, Dr. Wisnu, and all the participants that has been enriched the discussion itself today. And we have 10 minutes coffee break. We have, please enjoy for all the participants to enjoy the coffee and refreshments that are already been served. And we will be back 10 minutes to actually continue to the next slide and lectures from Prof. Lee for 30 minutes, and then we have already done and lunch and photo session. Yeah. Okay, thank you very much. See you in 10 minutes.
Many people come over and over, like it's never stopped, even increasing, to help patients from around the world. We design to maximize your experience. Welcoming environment to connotation and anxiety and stress. Focuses on delivering comprehensive treatment. Caring attitudes toward patient to help facilitate your needs and to realize patient satisfaction. This is not a job. This is a machine to fulfill their needs, their requirements. The comprehensive scope of clinical and health with our integrated system. The latest equipment is utilized throughout the hospital. Technology is critical to delivering our high standards of health. Patient care services are coordinated across the various functions, activities, and operating units of a system. Research and innovation leading the future of heart medicines. Serve with kindness. Wherever you are, wherever you need. We're here for you. Rumah Sakit Jantung Jakarta. A place where your heart feels safe.
Marilah kita menjadi manusia yang bermanfaat bagi orang lain dan juga orang tua kita dan negara kita.
Saya Dr. Fatima Rahmat, Presiden Komisaris Dikardia Indonesia. Selama lebih dari 30 tahun saya telah berada di industri kesehatan dan menyaksikan bagaimana cara kita melayani pasien terus berubah. Di dunia kesehatan yang terus berubah, di mana teknologi yang bergerak sangat cepat, tekanan regulasi yang semakin berkembang, dan ekspektasi pasien yang semakin tinggi. Kepemimpinan hari ini tidak lagi hanya soal mengelola organisasi. Kepemimpinan adalah tentang bagaimana kita berpikir lebih jauh, melihat sistem secara utuh dan memastikan setiap keputusan berdampak langsung pada kualitas perawatan pasien. Melalui apa yang kami sebut sebagai New Mind of Future Precision Medicine provides early diagnosis for accurate treatment to improve patient outcome. Kami memandang layanan kesehatan khususnya jantung dan kanker bukan lagi sekedar rangkaian tindakan medis. Bagi kami layanan kesehatan adalah ketepatan diagnosis, kecepatan pengambilan keputusan klinis dan kesinambungan perawatan pasien dari awal hingga akhir. Sebagai pemimpin, saya belajar bahwa kita tidak boleh hanya berpikir tentang layanan yang terlihat di depan pasien, tetapi juga tentang sistem yang berada di belakangnya, proses yang terjadi, collecting data, interoperabilitas data, penggunaan teknologi yang terkini dan AI, serta kolaborasi dan ketepatan informasi menjadi sangat penting. Inilah makna Think Beyond Services, membangun fondasi operasional yang memungkinkan dokter dan tenaga kesehatan mengambil keputusan terbaiknya pada waktu yang tepat. Karena itu kepemimpinan hari ini harus mulai melihat peran presisi medicine, predictive medicine, dan diagnostik klinik serta laboratorium klinik lainnya seperti genomik bukan sekedar unit pendukung, tetapi sebagai fondasi operasional dalam pelayanan rumah sakit sekarang ini. Laboratorium klinik dan diagnostik klinik serta imaging yang akurat, cepat dan terintegrasi bukan hanya meningkatkan kualitas diagnosis, tetapi juga mendorong operasional lebih baik, mendorong operasional excellence, efisiensi dan keselamatan pasien. Inilah peran kepemimpinan, memastikan setiap elemen sistem termasuk laboratorium dan penunjang medis lainnya berkontribusi nyata pada kualitas layanan kesehatan yang lebih baik dan berkelanjutan. Salam sehat dan salam kesehatan Indonesia.
Interventional specialists begin each day knowing one thing. Every decision matters. Their choices shape outcomes for the patient, for families and teams working in perfect coordination. Confidence is something they train for, strengthened through years of learning and preparation. Ready when the moment allows no hesitation. At Terumo Interventional Systems, we exist for those moments by supporting focus in critical situations and mastery across a lifetime of practice. Our learning strengthens understanding. Our solutions are intuitive and dependable, engineered for consistency and reliability. Because when every decision matters, there can be no compromise. Terumo Interventional Systems. When every decision matters.
Dengan
Dengan dibukanya Poliklinik Eksekutif Gria Kardia, kami harap dapat meningkatkan mutu pelayanan dan kenyamanan pasien loyal Rumah Sakit Jantung Jakarta. Di Indonesia, Rumah Sakit Jantung Jakarta hadir sebagai pusat layanan jantung berteknologi tinggi bagi pasien anak hingga dewasa dengan standar pelayanan yang komprehensif dan terintegrasi. Layanan kami didukung fasilitas penunjang diagnostik yang lengkap, mulai dari EKG, ekokardiografi, Holter, treadmill test, MSCT, hingga MRI. Penanganan pasien jantung diperkuat oleh tim medis berpengalaman yang terdiri dari profesor, subspesialis, spesialis jantung dan pembuluh darah baik dewasa maupun anak, serta tim bedah jantung yang berkompeten. Kami menyediakan layanan unggulan meliputi rotablator, aterektomi, IFUS, dan OCT, serta penanganan aritmia dengan teknologi PFA dan pemasangan pacemaker. Kami juga menghadirkan tindakan bedah jantung, mulai dari minimally invasive cardiac surgery hingga prosedur kompleks seperti bental prosedur. Kami juga menangani katerisasi dan bedah jantung anak mulai dari ASD, VSD, TOF, dan atrial switch operation. Dengan teknologi, keahlian, dan kepedulian, kami siap melayani Anda untuk jantung yang lebih sehat. Saya Diva, Virtual Assistant AI buatan Rumah Sakit Jantung Jakarta. Dan inilah JHC Hospital Mobile. Di era digital, pelayanan kesehatan harus bergerak lebih cepat, lebih mudah, dan lebih dekat dengan pasien. Mengatur dan memperbarui data diri dengan mudah. Hanya dengan scan KTP, data kalian akan terisi dengan cepat. Dan ini saya, Diva. Saya hadir untuk membantu Anda mengakses riwayat medis Anda secara lengkap dan terintegrasi. Semua tersimpan dengan aman untuk mendukung pelayanan medis yang lebih tepat dan berkesinambungan. Anda dapat menemukan layanan kesehatan terbaik dengan harga yang menarik. Memilih paket pemeriksaan sesuai kebutuhan Anda, membantu Anda merencanakan evaluasi kesehatan jantung dengan lebih mudah dan nyaman. Melihat dan mengelola informasi mulai dari pendaftaran layanan hingga informasi pelayanan medis. Anda dapat memantau jadwal kunjungan Anda secara mudah dan teratur, hingga melihat antrian layanan yang berjalan secara langsung. JHC Hospital Mobile memberikan pelayanan kesehatan jantung yang semakin mudah dan terpercaya.
Lithotripsy is a medical procedure to treat hard calcifications such as kidney stones or calcium in coronary arteries by breaking and fracturing the hard deposits. The Lithics HC IVL catheter is the first IVL technology to safely and effectively treat calcified lesions without the need for an external energy source. The Lithics catheter uses unique metallic hemispheres to exert Hertz contact stress energy to safely fragment calcium in moderate to severely calcified lesions. Lithics is flexible and can easily navigate tortuous anatomy. The lithotripsy mechanism of action is activated by simply inflating the Lithics catheter using a standard indeflator device. At low nominal pressure, the Hertz contact stress initiates calcium fragmentation. Lithics is designed to fragment calcium while maintaining safety and avoiding dissections and perforations. Lithics is atraumatic to soft tissue due to the large contact area and energy absorption. Deep and wide cracks can be seen in eccentric and concentric calcium, enabling optimal lesion treatment. In a clinical study, multiple cracks were observed in over 75% of calcified lesions. Following IVL, optimal device expansion and lumen gain is achieved. In the Pinnacle 1 study, residual stenosis was less than 30% after stenting in 100% of lesions. Stent expansion at minimum stent area was 96.7%. Stent expansion at maximum calcium site was 103.4%. Visit elixirmedical.com for more information.
Launch the slide, let everybody, so everybody can see the slide. Yes, please, Professor Lee, you may start the lecture. Thank you.
Okay. Hello everyone. Yeah, I'm Jumyoung Lee from Samsung Medical Center. So I think all you are a little bit tired. This is Sunday morning. So I'm gonna do very quick presentation. So, okay. You can see the mouse cursor. So my first lecture, I was asked to deliver two presentations. One is bifurcation PCI and second one is image-guided PCI. So I mentioned about these two trials. The DK-CRUSH-6 trial, they randomized the angio-based approach or FFR-guided conservative approach for the jailed side branch. And SMART strategy compared randomized the conservative management and the aggressive management for the jailed side branch disease. And as you noted in here, in aggressive PCI strategy, almost all patients underwent IBUS-guided side branch intervention. So DK-CRUSH-6 FFR group was the most conservative approach for the side branch. And the SMART strategy, aggressive group, was the most aggressive side branch intervention. And if you see the event rate, actually the aggressive side branch intervention had the highest event rate. This slide means that for unselected bifurcation lesion, side branch PCI can be sometimes harmful for the patient. And there are two trials in complex true bifurcation lesion. The definition 2 trial from China and EBC main trial from Europe. And EBC main trial compared the provisional approach and the upfront 2 stenting. Definition 2 also compared the provisional approach versus upfront 2 stenting strategy. In EBC main, there was no difference between the two groups. Definition 2 trial, upfront 2 stenting was better than provisional approach. However, this trial should be interpreted with caution. In definition 2 trial, 2 stent group was better than the provisional group. However, main driver of better clinical outcome was a lower risk of periprocedural MI, not spontaneous MI, not restenosis, not cardiac death or all-cause death. So this means that upfront 2 stenting can reduce periprocedural MI in very selected bifurcation disease. So when we compare side branch region length and diameter stenosis, you can see definition 2 trial had a higher region severity in side branch disease. So lesson from this trial, for the complex bifurcation, side branch PCI may influence patient prognosis regarding periprocedural myocardial infarction, not the future spontaneous MI. So I think the indication of upfront to stenting is like these three clinical scenarios. Number one, clinically important side branch. So size should be big, territory should be larger, and clinical situation, meaning in jailed side branch situation, patient feel chest pain, ECG change, or something. If jailed side branch shows up, no chest pain, no ECG change, or no vital sign change, that side branch doesn't need to be rescued. Number two, risk of losing side branch is extremely to be high. So very difficult wire access into the side branch. That means you may need upfront to stenting. And number three, rescuing side branch after significant jailing is expected to be very difficult. Only those three clinical scenarios we need upfront to stenting. So principle number one, in upfront to stenting, treat more severe lesion first is this safe strategy. So in this paper by my friend Professor Taekyu Bak, they compared the side branch first or main vessel first. So they classified those procedures into the which one has a more severe disease. So treating more severe lesion first is the optimal sequence in two stenting strategy. So for example, if more severe lesion located in side branch, upfront to stenting with side branch stenting first would be the wise choice. If more severe lesion located in the main vessel, we can use provisional approach plus or plus minus side branch stenting. Principle number two, intravascular imaging guided procedural optimization is essential. So in this study level meta-analysis, image guided procedural optimization resulted in lower risk of target lesion failure, cardiac death, MI, TRR, stent thrombosis, all-cause death, and NMI. So intravascular imaging guided optimization is essential procedure in complex two stenting situation. And in October trial, they randomized patient into the OCT-guided PCI or angiography-guided PCI in bifurcation region. OCT-guided PCI was better than the angiography-guided PCI. And in this sub-study, they evaluated suboptimal findings after OCT-guided PCI. So unintended stent deformation, USD, unintended stent deformation were observed in the 9.3% of OCT-guided PCI group. Among those cases, about half was abluminal wiring, another half is guiding catheter collision. If those unintended stent deformation were left to be untreated, the MACE rate was about 23% at 1 year. However, if that unintended stent deformation were correctly, successfully treated, the MACE rate was 0%. So this sub-study is very important because the actual operator, they used OCT, but in some case, they didn't notice at all this unintended stent deformation, even using the OCT. So use of intravascular imaging, not same with intravascular imaging guided optimization. So you should be able to interpret your imaging findings. And the Renovate Complex PCI trial, this was the first trial which showed survival benefit of image guided PCI than the angiography guided PCI in complex lesion. And this paper was a sub-study of the Renovate trial. In this trial, the most important imaging parameter was minimum stent area. So minimum stent area should be at least higher than 5.5 square millimeter. As you can see in this chart, patient with insufficient MSA, anyway prognosis was poor. In patient with sufficient MSA higher than 5.5 square millimeter, if we correct another suboptimal findings, which means edge dissection, malopposition, and insufficient relative stent expansion, you will have 0% target lesion failure during the 2.1 year median follow-up. And principle number 3, I think specific technique of tooth stenting does not matter. In this network meta-analysis, they compared 21 trials. And in this study, it looks like DK crush technique is the best tooth stenting technique. However, this should be interpreted with caution because historically, all the DK crush technique trials were done by same investigators from same Chinese medical centers. And there has been no external validation at all. And if you see, please see this graph. So DK crush trials, all those trials were positive result supporting DK crush was better than other technique. However, if you see this bar graph, actually the main difference was made because the comparator group was too poor outcome. Not the DK crush was better. So this network meta-analysis were biased because of the DK crush trial series. So I think the best tooth stenting technique is what you are most familiar with. Personally, I love Culo technique, and for the emergency case, crush technique, and I am very familiar with the Culo and crush. So that is the best technique to me. And if you're familiar with the tab is the best tooth stenting technique for you. And principle number 4, proximal optimization technique can facilitate the subsequent procedure. So in this analysis from COBIS-2 registry, if you see, in tooth stenting strategy, radial access, image-guided optimization, final kissing balloon, and proximal optimization technique were better than no performance of these techniques. So complex procedure requires complex optimization, like image, kissing balloon, and pop. And principle number 5, final kissing balloon with NC is mandatory in tooth stenting strategy. So if you did tooth stenting technique, but without final kissing balloon, that's gonna be very bad prognosis. So if you did tooth stenting technique, final kissing balloon is a mandatory. So let me show you some tooth stenting sequence in real case. This gentleman, exertional chest pain, and the distal left main bifurcation. And we planned to do Culo technique after IBUS assessment and stent sizing. And the actually circumflex was more severe than the LAD. So we did circumflex lesion first. So after implanting to main to circumflex stent, we rewired to the LAD, and the side cell was opened by small balloon, and the first kissing balloon, and then implantation to the main to LAD stent, and the rewiring, and the second kissing balloon using NC balloon, and followed by proximal optimization technique. So this is final result, and IBUS showed excellent stent expansion and a minimum protrusion of the neocarina. So treat more severe vessel first is the essential component. Another case, another angina patient, more severe distal left main bifurcation through Medina 1-on-1, and we planned the crush technique which I love the most. So lesion preparation using NC balloon, locate side branch stand, and prepare the balloon in the main vessel for the crush of the side branch stand, implantation of side branch stand, remove the wire, and then crush the stand. And usually, whenever I do the crush technique, I always check the intravascular imaging after crushing the side branch stand to check whether side branch stand was completely crushed or not. So in this case, this one was the side branch stand. As you can see in here, complete crush of the side branch stand is not easy. So we did additional crush and then implantation of main vessel stand. So in this situation, incomplete crush of the side branch stand, attempting DK crush technique can be very dangerous. Please imagine, after crushing the side branch stand, DK crush technique requires side branch rewiring. However, that wire can be go inside into the original side branch stand. After that, doing the kissing balloon will reopen the crushed side branch stand. And after that, if you try to close main vessel stand, that stand will stuck with the side branch stand. So if you are trying to do DK crush technique, you should always check complete crush of the side branch stand using intravascular imaging. So without complete crush, just conventional crush technique would be enough. So I just implanted main vessel stand and do the final kissing balloon like this, and followed by pot, and this one is the final result. So another option is the hybrid approach. The Korean Bifurcation Club, we are currently running smart DCB trial. So 520 patients with complex bifurcation disease, they are randomizing into the upfront two stenting or DCB-based hybrid strategy techniques. So these patients were randomized into the upfront two stenting technique group. So distal left main severe bifurcation and ejection fraction was 25%. So we did a side branch stenting first and then crush the side branch stand and put the main vessel stand and the pot and the final kissing balloon and additional downstream procedure in the medial AD. Let me just show you the final result. The distal circumflex disease was treated using DCB, and this one was the final result. And patient with the ejection fraction 25%, 6 months later, it was normalized. So I'm going to show you the DCB-based hybrid strategy. This patient, medial AD, total occlusion, and very severe diagonal branch disease. After pre-dilatation, this patient were randomized into the DCB group. So we did DCB angioplasty first for the side branch, and then implantation of the main vessel stand, followed by pot, and this is final result. So we are comparing those two stenting strategy in randomized controlled trial. And I'm going to move on to the next presentation.
Sorry, properly, what was the result of that trial, or still ongoing?
Yeah, it is still ongoing. We are enrolling the patient. Until now, about 40 patients were randomized.
40 patients.
So we need more than 400 patients. That's going to take some time.
Yes,
Yeah.
yes.
So, any question? Any question? Without any question, I'm going to move on to the next lecture. Okay. So let me tell you about image-guided PCI in complex regions. So I'm going to begin with my presentation this very provocative question. Why do we have to use intravascular imaging in PCI? In this study, they compared 10-year clinical outcomes between initially stented vessel and non-stented vessel. So regarding vessel-specific repeat revascularization or vessel-specific MI, there was no difference at all. This means that stent is not cure for the coronary atherosclerosis. Implantation of stent cannot change natural course of coronary atherosclerotic disease. So if you implanted suboptimally expanded stent, you are providing new stent disease. So once you decided to put the stent, that stent should be fully optimized to improve patient prognosis. And the Syntax 2 trial, they are well presenting how contemporary PCI can improve the procedure, patient prognosis. In this trial, 450 patients with complex lesions, among those patients, about 75% of patients were guided by physiologic interrogation. So they decided target lesion based on the FFR or IFR. And in the PCI, 84% of PCI were optimized using IVUS. And they used the most advanced stent platform. So compared with the previous Syntax 1 trial population, in Syntax 1, they used Cypher, no image-guided optimization, no physiology-guided region selection. So compared with this previous PCI, this contemporary PCI reduced the MACE rate in about 50%. So physiology-guided region selection and image-guided procedural optimization and use of advanced stent is most essential to improve patient prognosis. And in Samsung Medical Center data, in the institutional registry, we evaluated the prognostic impact of image-guided PCI in 10 years. So as you can see in here, compared with the angio-guided PCI, IVUS-guided PCI resulted in lower risk of cardiac death at 10 years. And the United States Medicare database, they compared the IVUS use and no IVUS use. As you can see in here, IVUS-guided PCI resulted in lower mortality. Although the use of IVUS is less than 7% of the overall PCI population. About 2 or 3 years ago, there had been major trials supporting image-guided PCI. The Renovate Complex PCI was the first trial conducted in South Korea by my center, and the Illuminate 4 United States, October Europe, Occupy another Korean trial. So the Renovate Complex PCI trial published in NEJM 2023, about 1,700 patients with all-comers complex lesions were randomized into the image-guided PCI or angiography-guided PCI. Primary endpoint was target vessel failure. During median follow-up of 2.1 year, image-guided PCI was much better than the angiography-guided PCI, and main driver was the lower risk of cardiac death following image-guided PCI. October trial, they exclusively evaluated bifurcation regions. OCT-guided PCI better than angiography-guided PCI. Illuminate 4, they compared OCT versus angiography-guided PCI. OCT-guided PCI resulted in the higher MSA. However, they failed to show the superiority of OCT than the angiography-guided PCI. Occupy trial is another Korean trial. They compared OCT versus angiography-guided PCI. As you can see in here, OCT-guided PCI was lower risk of MACE than the angiographic-guided PCI in complex lesions. And more recently, IBUS ACS trial from China, they compared angiography-guided PCI and the IBUS-guided PCI in ACS patients. The target vessel failure was significantly lower in the IBUS-guided PCI group. However, in this year, all those trials were positive results. However, this IBUS chip European trial, Optimal, another European trial, they failed to show superiority of IBUS-guided PCI. Why is that? So, if you read that papers, those European guys are saying they are too much expert in the angiography-guided PCI, so that was the reason of not seeing superiority of IBUS-guided PCI. Truly nonsense. So I'm going to explain that. So let's dissect their logic. IBUS chip and optimal trial, those are multi-centers, and only half of the participating centers were actually high-volume centers. And I think these are very different. Seeing, understanding, do something, and the quality of do something is totally different. In the IBUS chip trial, they did pre-PCI IBUS only in 60% of patients. And additional maneuver, additional procedure triggered by IBUS was only 40%. So 60% of IBUS-guided PCI group, they did nothing after the IBUS. Successful optimization, only 48%. Overall complication, 10%. Coronary population, 1.4%. And it is very same with the optimal trial. In our trial, Renovate Complex PCI trial, we did pre-PCI planning IBUS in 76%. And the additional maneuver triggered by imaging in about 50%, successful optimization much higher, and more importantly, complication rate was 3.4%. Coronary population 0.2%. So this is the contemporary quality of the PCI. European PCI, coronary population 8 times higher than Korean PCI. I think this is the reason of their negative result. Anyway, meta-analysis strongly support image-guided PCI can reduce all these hard clinical endpoints. And recently, Renovate trial, we published longer-term follow-up result. During more extended follow-up, image-guided PCI was much better, even though in long-term. So, and what about cost effectiveness? The cost effectiveness analysis from Renovate trial, of course, during the index admission, image-guided PCI resulted in the higher medical cost because of the cost of the intravascular imaging. However, during the follow-up, based on the lower event rate in the image-guided PCI group, the total cumulative medical cost is lower in the image-guided PCI group. And the ISR value of the image-guided PCI is minus $10,000. This means that 70% of this simulation support cost effectiveness of image-guided PCI than the angiography-guided PCI. So what was the reason that Illumin 4 showed negative result? When we compare the lesion profiles between Renovate and Illumin 4, the ACS much higher in the Renovate, and the upfront tooth stenting, CTO, ISR, calcified lesion, all these complex features were much higher in the Renovate complex PCI trial. So this means that image-guided PCI is needed for the complex lesions, not for the simple lesion. For example, CTO, one of the most complex lesion, the prognostic impact of stent optimization was highest in the CTO PCI. For the left main, actually image-guided PCI is a life-saving procedure. If you do left main PCI, intravascular imaging is essential to save patient life. And in this sub-analysis, when we have more complex lesion features, the benefit of intravascular imaging is getting higher and higher and higher. So what about the role of intravascular imaging in PCI guidance? So pre-procedural lesion assessment is very essential to identify culprit lesion, lesion characteristics, and lesion severity and mechanism of luminal narrowing and planning of PCI. So plaque rupture, in case of unclear culprit lesion, doing IVUS can identify this type of plaque rupture. And the equilucent plaque or posterior attenuating plaque like here, this is fibrous plaque and this is posterior attenuating plaque. This posterior attenuating plaque means highly lipidic plaque. You should prepare the possibility of no reflow in this situation. In my patient, highly vulnerable plaque, after balloon angioplasty, no reflow. And the plaque burden and positive remodeling is very important. So highly positive remodeling and posterior attenuation, you should prepare the development of no reflow. And in the OCT or IVUS, circumferential calcium or more than 3/4 of the calcium longer than 3 millimeter or minimum thickness higher than 300 micrometer or calcified nodule, you need advanced lesion preparation. Case example, this medial radial lesion in OCT, more than 3/4 of the calcium, length more than 5 millimeter, this requires LOTA or orbital arteriotomy. What about lesion severity? So what do you see this left main ostial lesion? Do you think this is very significant? Actually, FFR was negative, and IVUS and OCT, you can see this is not a stenosis. This is just a geographical variation. So don't do left main ostial stenting without having this detailed anatomical information. And the stent sizing, there are multiple algorithms, but this is current standard. The current European consensus, IVUS, EEL-based stent sizing. OCT is a EM or lumen diameter-based stent sizing. So you can refer this manuscript. And post-procedural optimization, MSA is the most important prognostic factor, not the relative stent expansion. Absolute MSA is a much prognostic factor than relative expansion. And Excel sub-study, higher and higher MSA, better and better clinical outcome. And for the atrial stenosis, we should land our stent at minimal plaque burden. The criteria is around 50%. And the intravascular imaging is very helpful to assess edge dissection, thrombus, intramural hematoma, or incomplete stent opposition. And as I showed you before, this unintended stent deformation should be corrected before you finish the procedure. And what about, among the multiple imaging parameters, what is the most important prognostic factor? First, MSA and the relative stent expansion, proximal edge dissection, and longer stent length. Those four parameters are major prognostic factors. And in Renovate trial, MSA most important. And you can refer this paper to standard optimization techniques. So I'm going to summarize my presentation from this study. In this study, we compared angio and IVUS-guided PCI. IVUS-guided PCI, of course, much better. But what about before and after application of standard optimization protocol? So this gray bar is image-guided PCI before application of standard optimization protocol. And this blue bar, image-guided PCI after application of standard protocol. So you can see, even among the same image-guided PCI, if you do systematic approach using standard optimization protocol, the prognosis will be much better. So take out the IVUS catheter, just manual pullback, see the stent. That is not image-guided PCI. Image-guided PCI requires standard protocol. Motorize the pullback, bookmark the reference segment, measure the stent length, measure the lumen area. After putting the stent, another motorize the pullback, assess the stent opposition, edge dissection, expansion based on the lumen mapping. If you see suboptimal finding, correct it and reassess the IVUS. That is the standard optimization protocol. And if you achieve successful optimization, those patients will have best prognosis. Stent sub-optimization is not better. And for which operators, this is my last slide. From Samsung Medical Center data, we classified our operators into the less experienced and more experienced operators. When we compare angio and IVUS-guided PCI, actually both experienced operator and less experienced operators, IVUS-guided PCI were better. However, the effect size, among the less experienced operator, the effect size of IVUS-guided PCI was about 2 times higher. So if your career is less than 5 years in PCI business, you should strongly consider to use systematic image-guided PCI. So this is my final slide. Clinical indication of image-guided PCI is a complex lesion. How to apply under the standard optimization technique and for which operators? All the operators, however, less experienced operators will have much benefit. And okay, let's summarize my presentation. Thank you.
That's an amazing, very packed, very fruitful presentation. So let's open the discussion with the floor. Anyone wants to comment or ask?
Yeah, 40-minute presentation is not easy. Yeah.
It's a different art.
Prof. Lee, I'm quite interested in the slide that you showed to us that the ostial left main looks very tight, but from the OCT, let's say we don't have any imaging in this kind of situation. Yeah. What are the things that you can use to determine whether the ostial left main is really tight or just
yeah, actually, let me tell you behind the story of this patient. This patient was a 38-year-old young male, no chest pain, and slight dyspnea on exertion, and the primary physician reported for the coronary angiogram, showing this result, negative FFR, and image like this. So I asked that physician, please reassess the cause of dyspnea on exertion. And they reviewed echo again. They found pulmonary hypertension and chronic thromboembolic disease in pulmonary arteries. That was the cause of dyspnea on exertion, not this one. So listen to your patient. Actually, patient had no chest pain at all. If you implanted main ostial stent during the angio, this patient will not have pulmonary vessel surgery for 6 months. And as you well know, pulmonary hypertension, much worse disease than coronary artery disease. So if you don't have any intravascular imaging, do the close history taking, measure FFR.
So when the catheter engages the ostial left main, there's no pressure damp at all, pressure ventricularization?
Of course pressure was damped because of the angle. Pressure damping itself does not tell you the severity of the disease. So Joaquin left catheter, because of that angle, pressure can be damped.
Okay, thank you.
Okay, I want to ask a question. So sometimes you have these patients with significant either a treadmill or a physiology study before the patient enrolled to the cath lab, and you find a lesion about 70–80%, then it is clinically related with the history of the patient, but you did the FFR as good as possible and it turns out negative. So which one will you trust better, your history taking and the functional tests, or the FFR to guide your intervention?
So let's assume your FFR measurement were correct. Okay? No pressure damping, no insufficient hyperemia induction, and your wire position was also distally located. So based on the assumption that your FFR was correctly measured but negative in patient with significant stenosis and positive treadmill test, my answer, FFR is correct. Treadmill test, highly false positive test, and it cannot locate which region is the cause of positive treadmill. It can be microvasculature, it can be another stenosis, it can be pulmonary disease, right? So coronary stenosis and positive treadmill test does not justify that one single stenosis can be treated. If that vessel is negative FFR, no functional significance. In that case, measure the microvascular function. Coronary microvascular dysfunction can be cause of positive treadmill test. Typically, if you did PCI for FFR negative region, patient's symptom will be same.
It's a bit difficult in the real world situation because you don't always have that microvascular evaluation straightfully. And
actually, it is very easy in my center. It is routine clinical practice. Yeah.
Just using the standard FFR, I think you need special software to do that.
Actually, no, just the Abbott machine.
Just the Abbott
just
machine.
Abbott Coroventis machine.
Yes.
And simple thermodelusion will give you all the information. Yeah.
So actually the question is, how much can you trust the FFR when you are actually clinically unsure that this is the lesion, but the FFR came out negative, which is not the uncommon situation that we found?
Yes, among the many stress tests, treadmill, stress echo, adenosine stress MR, SPEC, FFR CT, among multiple stress tests, FFR has the highest sensitivity, highest specificity, and the highest spatial resolution. And the clinical situation, FFR has been developed multiple randomized controlled trial. So there are very solid evidence, FFR negative, PCI no benefit. FFR positive, we can don't do procedure, but you need very close medical follow-up.
Thank you. So, anyone want to ask further regarding? I think there's lots of lots of things to be discussed in this. It is a very packed presentation. We can talk about bifurcation, stenting, vascular imaging, patient selection, all the randomized controlled trials.
Yeah, actually, in my center, it is kind of just a simple routine practice. So patient come into the cath lab, but most of them has a stenosis because we do CT coronary angiogram in outpatient clinic. So normal coronary angiogram that cannot be come to my cath lab. It's a waste of time. So taking angio, stenosis, subtotal or totally occluded, we straight go for the PCI. But intermediate disease, we automatically measure FFR or angio FFR, negative, just finish the procedure. But patient symptom is very typical angina, but FFR negative, we do microvascular evaluation.
So yeah, that will be the pathway, the standard procedure.
Yeah,
yes.
Kind of standard pathway, yeah.
And
I set up those protocol 10 years ago in my hospital. Even before I came into the Samsung Medical Center, FFR or CMD was not standard practice. Yeah. Even image-guided PCI, very limited use. But now all those procedures are very just default practice in my center.
So this is a question of statistics. So let's say that you have run lots of trials with thousands of patients. So and therefore you applied a systematic approach in your cath lab with a standardized procedure, and that is the best practice according to the statistic that you made. But let's say that you have this one special patients and can probably be a royalty or a high-rank government officials or some important persons. Then you should make a decision. Then the decision will follow the statistic that you made, or will you trust your clinical guts more? Because even though you said that it was statistically significant, it doesn't mean that it will significant in this one individual.
Yes, you're absolutely right, but we should consider that my clinical gut can be wrong. Because I'm not a perfect person. I'm very subjective person. My thought can be wrong. In the case, I always have discussion with my colleague, with my radiology technician, my nurse, my senior, my friend. What do you think about that? So listening to others' voice is very important because we are not a perfect person. Sometimes I can see some doctors, I'm always right. My clinical gut is right. FFR, you are wrong. IVUS, you are wrong. Angio, you are wrong. I'm right. That was the worst attitude in clinical practice. So I learned from my senior, Professor Hyunchol Kwon and Kubonggongu and Hyosu Kim. They always teach me, you can be wrong. So see the number, see the image, listen other people. That was my training.
Yeah, for me, that was the most important statements in this 2 days course. Yes, very nice. I would love to applaud that. Yes, very nice. Very good take. So probably, okay, sure, please.
In your center, when you do the FFR, do you use intravenous adenosine or intracoronary adenosine?
We do nicorandil, intracoronary nicorandil. Nicorandil, yeah.
For stress test? For FFR?
Yes. Because IV adenosine is very inconvenient for my nurse. They should connect the IV line the palm. So I set up the FFR in my hospital, intracoronary quarantine. Yeah. You can use papaverine. Yeah, papaverine intracoronary injection. It is more convenient for your nurse. Yeah. Anyway, in any procedure, if your cath lab step is not comfortable, you can do it many times, right? So everyone in your cath lab should be very comfortable for any procedure.
Okay.
Probably last question from anyone? Okay. If not, I think we're gonna close this session. Thank you for a very nice presentation and very good discussion.
Thank you, Prof.
I think we're gonna close up this session, please, Dr. Andini.
So maybe, thank you very much again, Professor Lee. So before we officially close the Jakarta Heart Center Live Series, we would like to ask Prof. Lee, or maybe after that, Dr. Wisnu, maybe to give some final words and key points from these 2 days. And how about maybe some reflections for your experience in Jakarta Heart Center Live Series? And yeah, maybe, please, maybe you can.
Thank you everyone. It was very fun. I met very good friend and person, and my staffs enjoyed a lot. And thank you very much, and hope to see you again soon. And I'm gonna hand over mic to.
Okay, thanks. Thanks. So again, the purpose of this kind of event is to provide the most for the patients. So by doing this kind of event, so we can provide more to the patient, more complex procedures, more devices that the patients needed, and also the best standard practice possible that the patients can achieve. Because at the current state, not all patients can have optimal benefits from the medical procedure. And that is from the point of view for the event. So from the point of view of the professional side, I think there are three main components to become a good interventional cardiologist. You have to be a good statistician. That means you know all the data, as Prof. Lee has showed us from the trials. Then you need to be a good clinician. That means you know the patient and you will take the best decision for the patient. And lastly, you need to be a good technician. That you know what you're doing in the cath lab and you can do it safely and effectively. And I think Prof. Lee has showed us a very good balance between those three. Become a good statistician, clinician, and also technician. And also, lastly, I just found out that you're probably a good philosopher too. By giving us some good take-home message that probably a very important one for me. So therefore, I would love to thank all of the faculties that has been involved deeply in this session. I would love to thank all our two, probably we should call you juniors or fellows, Dr. Andini and Dr. Edwin, who has been working well. All the committee from the hospital. And last but not least, the most important one is our sponsors from Thermal, who's working really hard to make this event happen. And also bringing us Prof. Lee here, and also from Elixir Medical for supporting us with all your great devices. So thank you everyone, and hope to see you all again in the future.
Thank you very much, Dr. Wisnu. Before we officially complete the JHC Live Series, we have one important thing left to do, a group photo, please. We would like to invite all of the participants to come forward to the stage so that we can have our group photo together.
So probably we'll take a picture just for closing, and then we'll have lunch.
Have our lunch,
then,
yeah.
Then it's all done.
Okay, so maybe please go up front for everybody so we can have our group photo. please, for all the faculty that has, and okay, Prof. Lee. Everybody, maybe we would like to invite Terumo and all of the committees.
Lights up. Today is enough.
Make sure everybody can see the camera.
We sat there and listened to the song on repeat. If tomorrow comes calling, it can wait outside. Right now, this little hour feels like a life. Today is enough. Today is enough. We can lean back, laugh loud.
So we would like to invite all of the participants to enjoy our lunch together that has been provided outside of the room. So thank you everybody once again. Let's enjoy our lunch and see you in the next